And Razia, you can make me co-host also. Or Rakib Bhai, make me co-host.
Yeah, it's recording now, I think.
Yeah, it's recording. You can make me co-host.
Excuse me, but for some reason the screen seems cluttered.
Yeah, Razia. Same for me.
I think whoever has stable internet connection can share it among you, and other person can talk.
Rakib Bhai, you have also the slide you can share, I think.
So I know the internet situation in Bangladesh is like very bad. So
Yeah, I think Rakib, can you please do that, because for some reason my laptop just hung up and I could not really move my keypad. So
It's horrible experience. Yeah.
Can you please share?
Yeah, you can do that also. Rakib Bhai, you can also do that.
Yeah, I'm sharing.
Yeah. Razia, you can stop sharing if you want. Yeah, from here we can start. 12.
Can you see now, guys?
Yeah, we can see, but it's a small format, not the presentation one. The mode is different here. Because sometimes it shows in another screen if you are using double screen.
Okay. Probably it's just a moment.
Yeah. So we really apologize for all the inconvenience.
Is that working now?
Yeah, it's working, but the screen is the different one. I think not the presentation one.
What about now?
Yeah, it's coming.
Is that okay now?
Yeah, we can see the small one, small version is still. Yeah, now it's perfect.
Okay, go on.
Yeah. So sorry to all. So see, you can see here different types of review paper already published. So some of our authors are in all this paper. So if you see here, the first one, it's a systematic review and meta-analysis of randomized control trials. So we call this one as intervention study. So the review is different for when we're using experimental study or intervention study or randomized control trial compared to the studies selected for systematic review and meta-analysis like observational study. You can see at the right hand prevalence of symptomatic pelvic floor disorder. This one is cross-sectional study. So, but this is also systematic review and meta-analysis. So it's more about observational study and the cross-sectional one. We have also trends in incidence of total or type 2 diabetes. This is, you see, it's published in BMJ. So this is really renowned journal and reputed journal, but still they are publishing only systematic review. It's not meta-analysis. So some people may have some misconception that if you don't do the meta-analysis, then it's not getting published in the good journal, or good journal is not taking your paper, which is completely wrong. So meta-analysis is not always appropriate. So we don't need to conduct meta-analysis always. And the right hand, you can see another one is a systematic review. That one is it was perfect earlier. Yeah, it's perfect. So this one, you see, this one is the experience of children and adolescents undergoing forced separation from their parents during migration. It's a systematic review, but it's it's a systematic review of qualitative research. Okay, so this is also a different type where it's really impossible to conduct meta-analysis. And in the left side, you can see cost effectiveness of lifestyle related intervention. So we did, this is a rapid review. Okay, so and another one, you see the scoping review. Okay, so here trends in incidence of diagnosed diabetes. This one is published in the Lancet journal. So Lancet published this one, and see, this one is also like from low and middle income countries, and it's published in a really good journal. So systematic review and meta-analysis, if you like conduct it in a rigorous way, it has huge chance to contribute in the existing scientific knowledge. And the first study you are looking at, safety and efficacy of testosterone for women. This is kind of groundbreaking research work done by our instructor, Dr. Rakibul Islam. And just based on this evidence, for the first time, there has been an international guideline prepared just based on this research. And after publication of this research, and there are lots of policies now developed regarding testosterone treatment and this assignment thing. So that's why systematic review and meta-analysis is really important, and it can contribute to the, like, I would say, evidence-based medicine, as well as if you want to do evidence-based policy making, there it could be really helpful. And there are multiple types of, so when you should conduct which one, that's really important. And how can you do that rigorously? That's what we'll know. Can you please move on? Yeah, so here you see there are like different types and different, so Andrew Booth and his colleagues, so this guy taught us systematic review and meta-analysis during our MPH. So they published a paper, and in that paper it was only based on what are the like different types of review people conduct. So they mentioned that 14 types of review are there. So in 2009 they published this article. So you can see, maybe you are already introduced with some of the type of these reviews. We will not talk about all of these. So critical review, usually we do that, it's kind of traditional or narrative review. And literature review we always do to write our manuscript, right? And for here comes this mapping review and systematic map, and what does it do? So I want to talk a bit about this one. So you see, it's a what is this? It's a map out and categorize existing literature from which to commission further reviews and or primary research by identifying gaps in research literature. So mapping review, this is really important when you want to know what are the existing evidence in the field or on the research question you want to get answer for. So you want to know existing literature, existing research, what are the gaps, and in which portion you can address. So that for that reason, particular reason, you do this mapping review. Okay. So here the appraisal is there is no formal quality assessment, which is different than the systematic review, because in systematic review we do formal quality assessment thing. Okay, and for the synthesis it's more graphical and tabular presentation, and for analysis it's not like, I'll not say it's rigorous statistical analysis, it's more descriptive analysis here we conduct or we do. And then you see this one, the meta-analysis. So this is important because with systematic review, we do meta-analysis. First of all, if it's a quantitative research, only then we can do the meta-analysis. But if the studies we included, those are quantitative, but still it's not always possible to conduct the meta-analysis. Meta-analysis, it's possible if we see we have the studies we have selected, those are suitable, appropriate, and according to the inclusion and exclusion criteria we have set for, if those meet those inclusion and exclusion criteria, only then we can go for meta-analysis thing. And in meta-analysis, if I just briefly mention you what is that, so I'll say if you have like maybe 5 study, it's a quantitative, you think those meet the exclusion and inclusion criteria also, and then those from those 5 selected studies, you retrieve their effect estimate, and then we pool that. So I'll not say exactly that's an average. So it's a kind of average of 5 studies effect size. Effect size means it could be coefficient, beta coefficient, it could be risk ratio. So mostly those. And we pool that. Pool means like we combine and we generate or produce a kind of average estimate or effect estimate. And that's a meta-analysis we call here, or like the thing we do actually. And in mixed studies, we include both quantitative and qualitative studies. And based on that, we do different type of analysis. It could be, we can include like quantitative analysis part also, and as well as the qualitative. Akiba, can you please move? Can you please move? Next. Yeah, thank you. So and okay,
I think, Joel, you skipped the previous slide.
yeah, Rakib had previous one.
Yeah.
Yes, this one, perfect.
I think you are getting a little bit later. That's our problem. So
Yeah,
the flow.
yeah, maybe for slow internet, it's okay for the lag. Okay, then like I'll say most available reviews among them, this one is the rapid review we usually do. Another one is the scoping review. And then what we talked about the system, like the session today we are going to conduct, it's more about the systematic review. So in rapid review, actually what we do, we search like because maybe we don't have much time, okay, so we quickly want to know about the existing literature, existing evidence, and what are the things there and what can we do. So to have some quick snapshot about the evidence, about maybe it's about a policy, it's about an intervention, it's about a medicine, so we do this rapid review. And about this scoping review, a preliminary assessment of potential size and scope of available research literature. Actually, the research question you have, what are the scope? Do you really have sufficient number of literature or sufficient number of research article based on which we can conduct really a systematic review or not? So that's what we do with this scoping review. And here we don't have any formal quality assessment, and also it's mostly tabular and narrative synthesis we usually do. And then the final one, I'll say, which one is the main focus of this session. It's about the systematic review. Razia already talked about it. And besides that, we also showed a paper. It's about the qualitative systematic review. So maybe someone or some of you are not working with the quantitative research actually, but you want to conduct a systematic review of a qualitative research. So you can also obviously do. And I already showed you the publication we have based on qualitative research papers. So we call this qualitative evidence synthesis or meta synthesis. And our instructor or research person, Dr. Rakibul Islam, will show later on about this one also, and as well as the systematic review and how can you conduct the meta-analysis. So in systematic review, if I just briefly say this 4.1 is the search. How do we search? So we really conduct a rigorous search. So aims for exhaustive and comprehensive searching, and it's based on available databases. I'm not sure whether you are aware of the databases or not. Maybe you hear about the PubMed, and then also like Science Direct, Web of Science. So Web of Science is okay, but PubMed is not a really also the comprehensive database. So for comprehensive databases, you need to have some access. So mostly the people who are studying abroad and some of the Bangladeshi universities, they have access to those databases. So usually in a rigorous systematic review, we include the librarian, because librarian has this access also, and they are trained of searching this, doing this, conducting this comprehensive search. And then about the appraisal, we do have an inclusion and exclusion criteria, which is really important, and we do assess the like risk of bias or quality. So that's important in systematic review also. And analysis, it's both like a tabular, narrative, and here, if it's possible, we go further for the meta-analysis. If not, we are done with the analysis process of the synthesis. Rakib, I think we can move. Next, please. Okay, so basically, we didn't discuss a lot of type of reviews, but by this time you have already I'll not say learned, you know that among different types we have really two different distinctions. One is traditional and narrative review, another one is a systematic review. So our concern is about the systematic review. So what is narrative review? Particularly narrative review, critical review, those are done by expert of the field, so who have some knowledge, and they do some narrative synthesis about existing evidence, and they also put their subjective expertise or their comment on that. So usually when we do our literature review, or we do like traditional review article, so we use this narrative reviews technique, or this is called the traditional review. And systematic review, it should be why we need then a different review, which is called systematic review, because when an expert is providing some opinion or writing something that might be biased. Okay, that's one thing. Another most important thing is the study that expert use or refer to conduct that review. Those studies might not be selected or included through a rigorous process. It could be also subjective, and maybe we are just going to Google or writing about a topic, and we just downloaded some article and then we review and we write a review article. So that's really biased, because we might leave like a lot of other valuable or rigorous, or I'll say excellent studies, which are really good in terms of evidence, but we could not include those. Or maybe the author or expert who conducted that narrative review did not include, and we don't know whether they have searched rigorously or not. So here comes this bias thing. So the narrative synthesis they are producing, if not through the systematic review process, then it's going to be biased. So then we need something scientific, which is rigorous and which is reproducible, and someone else can follow the same step and produce the same evidence using the same guideline. Then it comes the systematic review, and we can call it like it maintains this scientific research process. So that's how, and that's why this systematic review is really important, and we can call that this is kind of an empirical, or like also scientific method, which can ensure like unbiased evidence or produce unbiased evidence if we follow the rigorous process thoroughly. So a systematic review is a review in which there is a comprehensive search for related studies on a specific topic, and those identified are then appraised. So you see, we do the quality assessment in terms of appraisal, we do risk of bias analysis also, as well as we do synthesize. Okay, and if possible, we also analyze this statistically, and that's the meta-analysis thing. Please move on, Rakib bhai.
Can I ask you a quick question?
Yes.
I don't know whether you will cover that. I think you will cover that. So I'm still.
Rakib bhai, you can go the next one. I think it's okay.
I think you will cover that, but I'm just asking a basic naive question. So meta-analysis is is it a distinct type of review, or is it part of the systematic review? Because sometimes we see people do systematic review and then within the systematic review, they do meta-analysis. So I don't know whether you will distinguish between these two concepts.
Thank you so much. So you see, when we are talking systematic review and meta-analysis, so here comes two are completely different type. And when we see Andrew Booth and his colleague identified the different types of review, they also mentioned that it's a different, because meta-analysis, it's a different part and systematic review is different part. But systematic review is precondition to conduct the meta-analysis also. So if we don't do the systematic review, then we don't get the suitable or appropriate studies to include for the meta-analysis. So here comes the little bit distinction that for meta-analysis, systematic review is the precondition. You have to do the systematic review, otherwise you don't know which studies you are going to include for the meta-analysis. But you don't always need to conduct the meta-analysis, because when you are done with the systematic review, sometimes you will understand there is no scope to conduct the meta-analysis, because meta-analysis is all about just a statistical synthesis rather than a whole other process. So the studies will be including for our meta-analysis, those will come through the systematic review process. So I think when our like Rakib Bhai and other will discuss more and show you the process, and we'll talk about the steps, then it will be more clear.
I'll just add to this point. So this is a great question, and I'll just give you an answer with an example. So for example, if we want to see that if beta blockers help in any cardiovascular disease, and we do a literature review on that, can you assume what would be can you guess what would be the problem with that? So we want to know the effect of beta blockers in any cardiac disease, and we conduct a literature review. And we plan that we'll do a literature review, and whichever studies we include, we are going to meta-analyze. So the main problem is that when you meta-analyze information that is not from all the studies that have been published, you might miss out some very good studies, and the effect you actually tell, which is not the right effect. You might, for example, miss those studies who say that they are not beneficial, and you only pick and choose those studies that say that that it is beneficial. What will happen? You will overestimate the effect. You will say it is beneficial, but the main problem is that you miss the studies that said that it wasn't beneficial. So the effect estimate is the main thing in meta-analysis, and you don't want to give a wrong estimate for that, because it is used in clinical decision making. So you need to be very comprehensive when you do a systematic review.
Okay, so Rajia, does it mean that within the systematic review, you have a set of studies, and on those subset of studies, you conduct a meta-analysis, right?
Yes. Yes.
Okay, perfect. Thanks.
Razia, do you want to? I'm not sure, Umar, that is it comment or Razia, do you want to comment on that in chat box by Umar Dad?
Oh, I just mentioned my view on what is meta-analysis, what I think of meta-analysis. So that's what I just wrote in the chat box.
Yeah, I think it's a little bit different. What I understand, that meta-analysis should not be one step ahead. It should be rather later. You know,
based on my understanding, I think meta-analysis is not always possible when you conduct a systematic review, but when you see that you have enough results, particularly the numbers, and then you can do some statistical analysis of those just to determine the effect of that.
That's a kind of hypothesis and pre-working things, but meta-analysis should be you will see the data after extracted data. You will see that, and whether there is huge heterogeneity or not, then you will decide whether you will go for meta-analysis or not. That means the systematic review is first. That systematic could be data synthesis, and that systematic could be data extraction. That systematic could be data charts, and then you go for meta-analysis, so that this is really preclude meta-analysis or include meta-analysis.
Yeah, I think that makes more sense now. Thank you so much, Rakib Bhai and Razia, to contribute. So I'll just sum up with one thing, Umar, that why we had that objection about the word ahead. Because when you talk about ahead, we have this tendency that if we are not doing meta-analysis, then the way you describe it's perfect. But just about the word ahead, that's why I have that objection, that we have a tendency that if we don't do the meta-analysis, maybe it's an advanced one, then it's not good. So we just try to talk that one, that it's not like the thing. So without meta-analysis, your systematic review could be perfect. It could be really a good evidence also. And you have also shared already that why we cannot always conduct this meta-analysis. Okay, so it was a nice discussion also. Thank you so much all for contributing. So here you see we have already talked about difference between traditional narrative reviews, traditional or narrative reviews, and systematic reviews. So basically the thing is, it's in terms of the formulation of question and the method we are using and the search strategy we are using, which are different in terms of narrative reviews and systematic review. For example, we have we have question both in traditional review and systematic review, but in traditional review it's a very broad question, not specific and to the point like the systematic review one. And the method section, usually in narrative review we don't have well-described method, but in systematic review we have a method. We also predetermine whether we'll include qualitative studies or quantitative studies or both. Is it gonna be like scoping review? Is it gonna be repeat review, or we are doing really a systematic search and systematic review? So in terms of methodology, it's also completely different. And search studies, we have talked that in traditional review we don't use really proper search strategy or comprehensive search strategy. And then here comes the quality assessment of identified studies. So in traditional review, the quality assessment, it's more about subjective or expert opinion, not in terms of some established indicator or method to assess the quality or to assess risk of bias. And in terms of data extraction, we follow really a well-established, it could be a format, it could be a structure, it could be a tabulation format. So this is more a structure for systematic review, which is not true for narrative review or traditional review. And then in terms of data synthesis, so synthesis is also more subjective in narrative reviews, where in systematic reviews, sometimes you can do meta-analysis, what you already talked, if possible, if the things are suitable, if the studies are appropriate, if we think in terms of all other inclusion and exclusion criteria, we meet all criteria to do meta-analysis, then we'll do the meta-analysis also. And despite that, still, it's not like the narrative review. The systematic review synthesis will be completely different than the narrative review, because here it's more structured, well-structured, systematic way we do that, or we do synthesize. And in terms of heterogeneity, in narrative review or traditional review, we don't have, we don't do that. It's more subjective. But in systematic review, we test this heterogeneity graphically, statistically. So that's how we can decide that, okay, whether we can go further or not. And in terms of result interpretation, so this traditional review interpretation could be more biased than the systematic review. And the evidence, that's why we are producing through the systematic review, is one of the best evidence ever in research, I would say. Rakib bhai, please next. We can move, yes. Okay, so it's over to you. Thank you so much. So our next instructor, Dr. Rakibul Islam, will take over from here. Rakib bhai, you are muted.
Thank you, Joel. I will be discussing steps in systematic reviews very briefly because there are some steps have already been discussed back and forth, but I will go very systematically what are the processes you should follow when you are doing a systematic reviews. And then these parts again will be discussed more detail when I'm going for meta-analysis. I mean, what kind of meta-analytical approach you will be undertaken when you are doing systematic reviews and meta-analysis. So before doing a systematic reviews and meta-analysis, and mind it, this systematic reviews applicable for both for qualitative and quantitative studies. So before conducting or undertaking any systematic reviews, the most important thing is that you should have good review team. So that review team should include clinical or content expert and methodological expert. That methodological expert could be statistician or epidemiologist, but whoever, epidemiologist or statistician, but they should have pretty much both AP knowledge as well as statistics knowledge. And for clinical or content experts should have very good understanding about the topic, especially the outcomes. You can think about if your outcome or research question is not correct, then the evidence you are generating would be misleading, which is the big problem nowadays. So the research question should be then formulated. And as I said, the research question should be formulated mainly by the clinical expert or content expert. The next thing is about the methodological thing, which is PRISMA checklist. When you are conducting systematic reviews and meta-analysis, you should follow the PRISMA checklist that contain 27 items, main item, and there are a lot of sub items. So this is based on updated PRISMA guidelines, which is published in 2020. Just to let you know that whenever you are using any guideline, or this is in fact for tips for publication, whenever you are using any software or any guideline, always try to use the updated one. Otherwise, you will be asked to update your manuscript. So this is really time consuming. And then you should develop protocol. That protocol could be very informal protocol, or it could be very structured protocol that could be published. As we shared a couple of protocols in our case for randomized control trial as well as observational studies. So we ran and we developed protocol and then we published protocol, but not necessarily that you have to always publish protocol, right? But what you can do, you can write an informal protocol and then you should register that protocol in the registration platform. The most common and platform is Prospero, that is the International Registry for Systematic Review and Meta-Analysis. The reason for, and the other one is Research Registry, which is really not that very common, especially there's some limitation for Research Registry, but Prospero is very, very important for systematic review and meta-analysis. So why we need to do registration. This is actually, again, the concept of reproducibility and avoiding duplicacy, right? So if you are registering your protocol, then maybe at the same time, when you are thinking about conducting a systematic review of meta-analysis and meta-analysis, then maybe someone in Canada or in US or other parts in the world are also thinking to do a systematic review and meta-analysis on the same topic. So as a clinical expert or methodological expert or as a review team member, your responsibility to look at online or in Prospero whether there is similar kind of review already someone has started. If this is the case, then please stop your systematic reviews because this is waste of time and it's a kind of duplication, right? Then the next step is database search. So there are many formal databases. So these are Medline, Embase, PsycInfo, Central. Central is the clinical registry of Cochrane Centrals, and another is Scopus or Web of Science. So you no need to do all database searches. Is depending on what kind of topic you are going to undertake in your systematic review and meta-analysis. There is these all are formal databases, as I said, and this is paid databases. So there are a lot of low and middle income countries, and people don't have access to these databases. So what they do, you will see nowadays, people use PubMed and Google Scholar to do their systematic reviews and meta-analysis. This is highly problematic because your intention is to develop a robust evidence for clinical practice or policy practice. However, if you are unable to find or missing many important articles, then your systematic reviews or meta-analysis are not going to provide any robust evidence. So the intention here is to, or suggestion here is to, if you don't have access to these databases, then what you should do, you may contact with your friends who is living in abroad and they have access, then you can get, you can ask him or her to be involved in your team and help with the database search. Then the next section is that I think I would say the studies exclusion, inclusion should be maybe should be discussed before database search with the clinical expert and methodological expert sitting together, that what should be the exclusion and inclusion criteria, and then they will go for database search. That I will discuss in our formal paper. And then the next step is, there are some process in between that Razia will speak about, like what are the ways to retrieve articles and how to put those citation and how to manage those citation using different software or a reference manager. And then you remove your duplicate articles and you find your final included articles based on your inclusion and exclusion criteria. Say, for example, you got now 20 articles that actually met all inclusion exclusion criteria. Now your responsibilities or your work is to extract data from these articles. The next step is data analysis. So what kind of, probably someone is not muted, is mute. And the next step is data analysis. So once data extraction is done, then you have to look at carefully what kind of data you have got, what are the heterogeneity or variation between studies or within studies, whether this is really meaningful to combine this data in a statistical approach. So if this is not the case, then you really take decision with your clinical expertise that this data is not really appropriate to aggregate or quantitatively synthesize. So in this case,
Excuse me, sir. I
sorry,
need to interrupt. Someone is background noise is
yeah, that
disturbing.
I said it's really little bit distorting. Distracting. Who is that? Can you please? Well, can you, hello, Rajiv, can you please? Is that okay now?
Yes.
Yes.
Okay. So what I say that if you think that this is not, data is not really supporting to do meta-analysis, then this is completely fine because you can go for just quantitative synthesis. So this is fine because when I did my first postdoc with CDC and Becker Heart and Diabetes Institute, this is very high level systematic reviews, but it's without meta-analysis. So the idea came from the head of the CDC, who has been working there more than 25 years as a epidemiologist and statistician. And he actually found some kind of pattern in the incidence of diabetes. And last 20 years or so, people think that diabetes is really increasing across the world. But that should not be the case, is because more than 30 years, there are a lot of preventive measures have been undertaken, especially physical activity, taxing on sweet and sugary things, and building parks and cycling. So that should actually should give a kind of idea that diabetes should reduce over the period of time, and that was first time shown in some kind of individual data in US, and then he came to the conclusion or kind of hypothesis that what could be then seen in across the world, whether diabetes is really increasing or stabilizing or decreasing. And looking at the prevalence data, it is really impossible to comment on that because those who have little bit experience about the epidemiology, you know that prevalence is really existing cases as well as new cases. So that means when diabetes is well managed, so prevalence should be always increasing because people are living longer and new cases are adding with that prevalence. So it's again increasing. So idea is that we should look at the incidence of diabetes rather than prevalence of diabetes to understand the real fact of diabetes cases. And then they started this review, and first time, this is very fascinating results that because incidence data is very precious data, and it's really hard to get almost no data from low and middle income countries, but most of the developed countries data. And we found that very interestingly, most of the developed countries diabetes incidence is really declining. So you can see this is kind of analyzing data quantitatively, but not using meta-analysis. But that has been published British Medical Journal, which is one of the top journal in medical science. Then another part, when you complete your data analysis, the next part is assessing risk of bias or quality assessment. This is very important, even if you publish your systematic reviews and meta-analysis, or normal systematic reviews, there is a lot of problems with this published paper, because most of the people are really not discussing risk of bias in relation to their findings or interpretation of the data. So risk of bias is really very important when you are interpreting your results and providing kind of policy suggestion. So this is very important, and there are a lot of tools really developed for observational studies and experimental studies. So for experimental studies, mostly use, especially for randomized control trial, mostly I would say it's a kind of monopoly. I mean, for randomized control trial, the Cochrane risk of bias tool is used. And also for non-randomized control trial, this is also use Cochrane's another risk of bias tools. But for observational studies, there are a lot of different tools have been developed by different organizations or people for cross-sectional studies, case control studies, or cohort studies. Then once you assessing those things, another things I should mention about the risk of bias along with the grading, which is really very top level kind of summarize, top level way of summarizing your quantitative data, usually using the grading system. It's very few people actually do that, but you can use that grade system as well when you are interpreting your results. So the next step is that once your risk of bias is done, then you prepare your manuscript, and then there is a kind of critical appraisal tool for reviewing your systematic review. So you write your paper, then you go through each step of this appraisal tool, that whether you cover all those areas. If you are happy with that, maybe there are some areas will not be applicable for you for your review, but still if you go through that and you understand that whether my review is robust or not, and then you can go for preprint. But it's for systematic reviews, it is not really recommended, or it's not really very common to go for preprint, but you can directly submit for publication. And then I will talk the same thing in a kind of pictorial form. You can see a roadmap for systematic reviews and meta-analysis. This is this kind of process should be also discussed when you are using that critical appraisal. For example, you can see that the things I have discussed is very systematically written here. That review guidelines on systematic reviews and prepare a protocol and identify appropriate database and sources of studies. This is done. Run searches on all relevant databases and resources for sources. For example, if you are doing systematic review and meta-analysis on randomized control trial, then central should be the most relevant database. Along with that, the trial.gov.org should be also or must be also charts, because there are many trials. So it has not been published, that I will discuss later, but has been registered and data is over there. So you should search that as well. But if you are doing a systematic reviews on a depression or anxiety, then maybe PsycInfo should be one of the most relevant, along with some other databases. So you will decide based on your based on your topic. Then probably the next step is, once you search your database, then you import that in different software, maybe EndNote or Covidence that we'll discuss earlier. And then once you got these articles retrieved in your reference manager, then you have to scan those titles and abstracts and finally full text. And that process should be done by 2 persons. This is the most important, and that's why this is actually systematic reviews. If only single person is doing screening or data extraction or risk of bias, then this is not the systematic reviews, because that should be highly biased, or it could be reporting error or reporting bias. So for example, if you do rapid review, then you are not required to do that. If you are doing scoping review, then you are not required to do this kind of screening or data extraction on risk of bias by duplication. So you can see I have discussed, and then articles considered eligible for full text review by 2 reviewers, again by duplication. Then you extract the data, as I said, and then you go for statistical analysis using different software. If you are doing systematic review, Cochrane systematic review, then you are more likely to using Rebman. But Stata is the most common statistical software people use for systematic reviews and meta-analysis. And why this is important, I will discuss later, because there are a lot of options to change that you cannot do in Redmond. And the final is you just write your results and publish as a report or a scientific article. I think this all. If you have any question, I am happy to answer.
Can I don't know. Can I go forward for a quick question?
Yeah, sure.
Can you please go back to your one slide back?
Okay, let me share.
This is a theoretical question.
Okay,
and I really don't like to, just right. Just one slide back.
Yeah.
No, one more.
This one.
Yes. Yeah. So I'm just thinking, because you gave an example from one of your works, and then you talked about like formulating a very robust, unique research question. So I'm thinking about from a step perspective, like in terms of formulating a research question. Do you do a scoping review or any sort of review just to guide you that you are formulating a question which is very unique?
Yeah, that's a very, very important question. That is the very basic thing. I was thinking to talk a little bit more about, as I said, in the data analysis section based on my paper. So you can see the first thing is the review team, right?
Right.
So in this review team, I will say my lead author, my supervisor, who has been working on testosterone therapy last 30 years across the world. Most of the reviews have been done across the world. Somehow she is involved in that project, right? Even there are some randomized control trials that produce negative results and has not been published, and she is aware about that. So, and there is a lot of controversies about the efficacy of this drug, because there are some medical doctors here, so they will understand that testosterone is a male hormone, but there is little for women as well. And with increasing age, especially after menopause or during menopause, testosterone actually declines sharply. And that's actually diminished their sexual function. So last 30 years, it has been shown that when you note that testosterone has not been approved by the FDA for men. This is approved for men, but not for women. So
Right.
last 30 years, that testosterone has been used as an off-label drug for women's sexual function. And always it has shown that testosterone is really effective to improve your sexual function. But the problem is that you don't know the harms of this drug. And this is the big problem. People always think about the positive thing, but sometimes the negative could be more dangerous than the benefit. For example, for this case, say for example, sexual function is not that big like your death, right?
Mhm.
But this drug has been given for 12 weeks or 8 weeks or maybe 16 weeks, and then your sexual function improve. But what could be done or what could be the effect if this testosterone given 2 years, or what could be even given for 8 weeks, but what could be the indirect effect after 5 years? And there, because no randomized control trial is really going to continue for 2 years or 5 years, it's very expensive. But we have seen in our review, I will tell later, that it has really very dangerous effect. So if your sexual function improve, but you are going to die from stroke or heart disease after 5 years, there is no point of improving your sexual function. So that's a controversy. But
Right.
when that review team actually is the leader of the world of this topic, and she knows the benefit and harms, and she has huge understanding, but she had no opportunity to look at in a very concise way. So then the idea came, we should look at that. And exactly what I said for diabetes incidence, it comes from the person who is really global leader. But what
Right.
we do nowadays, we do systematic reviews without having any content knowledge. Just
Yeah.
we follow some steps and we publish, which is really problematic. I think I think it's I discuss a little bit more because it's really so important question that will be really helpful for all participants when they are doing systematic review and meta-analysis.
So my second question, just related to this. So as you have vast experience of publishing systematic reviews, what's your suggestion like to formulate a research question?
I would say what you started before that, or that we should look at PubMed, or I think this is a kind of very basic things. If someone is going to look at or interested to do something, then say for example, I or you are not expert on a topic, but you got some methodological expertise. So what you can do, you have some knowledge but not very expert, but you can have a look on PubMed, and you can do some Googling or maybe some Medline, and you find there is no systematic review and meta-analysis. Then you contact with someone who is working on those areas or on this topic for many years and have very strong clinical expertise. Then you collaborate with him or her, and then you initiate. You will be the lead, but you will get constant support from someone very expert, so that you are not deviated from the robust evidence. Does that make sense?
Okay, thank you so much, Rakib Bhai. I know I'm asking too many questions.
No, I think that's important. There
Yeah,
are
so
some young people might not ask question.
yeah, I'm a PhD, but I'm learning a lot. So my last question on that. So like, is it like you started? I mean, from your experience, you started with a project with a research question in mind, well formulated, well thought out, and then once you get all the evidence, I mean, all the studies based on your inclusion and exclusion criteria, have you had any experience of changing your research question or tweaking your research question?
Yeah, of course, of course. That's very important question, even very high level question. That is called deviation from your protocol, right?
Okay.
So that's why it is suggested in open science nowadays that what you want to do, even in an original research, you should write protocol, and that should be shared in open science. So that it has producibility, right? So you should write protocol, you should do everything you have in mind. Then after doing, database search and data extraction, it could be quite different. Say, for example, you are planning to do a meta-analysis, right? And your data does not support, then you cannot go for that. For example, now I am doing for my PhD student as well as 2 postdoc students here. There are 6 systematic reviews we are doing now, and 2 is pretty much done, 3 is pretty much done, and we had planned to do meta-analysis, but all three of them are really precluded that we cannot go for meta-analysis due to huge heterogeneity in terms of statistical approach, in terms of data transformation like log transformation and raw data, as well as the number of variables have been adjusted in included studies. So for example, one study adjusted age and BMI, another study adjusted age, BMI, and hormone therapy, another study is adjusted age, BMI, hormone therapy, physical activity, depression, diabetes, comorbidities. You can see when different people adjusted different confounding variables, their estimate could be quite different. But if you want to synthesize quantitatively, like pooled odds ratio or risk ratio, that is dangerous. You can do that. You can do that, obviously. You can do in statistical software, and you can find a nice graph, and you can report that. But that is catastrophic. You cannot.
That is, yeah. No, I understand. Thank you so much. I'm really sorry for the rest of the group. I took a lot of time.
That's our intention to upskill. I'm not expert. As I always say, I have limited knowledge, but I try to share my experience.
Okay, Dr. Rakib Bhai is so benign, and I know that among us, he's the expert in systematic review and doing for like about more than 10 years, I would say he's doing this thing. So I just would just want to thank you that you mentioned about the odds ratio thing, because most of the studies we are conducting in LMICs, so mostly we are doing odds ratio or logistic regression. Kind of, if it's not case control study, this is the worst one. And when in terms of when we are doing meta-analysis and thing, and if you want to do meta-analysis, this is also kind of worst one. So always keep in mind, so why you are doing meta-analysis, and if it's odds ratio, like it's really tough and it's statistically possible, but in terms of pooling and metasynthesis, this is not the good one. And Dr. Rakib already mentioned it. So be
I
careful.
got another question from Sharmin Sultana. I think it's you asking, would you please tell us about preprint in details? I think there is nothing to tell about preprint in details. As I said, for systematic reviews and meta-analysis, there is no point of doing preprint. And the concept of preprint actually become very available during COVID-19, because this is another things for rapid review. So there are a lot of new drugs come to the market, and to see their efficacy before going to publication, they try to preprint, and so that people can use that evidence for clinical practice. So this is mostly for original research, but I would not say using preprint, and that will be very helpful. But rather you should go for PROSPER registration or registration in research registry, and this is kind of very informal protocol. But if you want to go even one step further, then you go for publishing protocol. especially when
Well,
it's doing.
Excuse
randomized.
me, can I have a very small question, little question? I will take
No,
little
it's a
time.
big question is fine.
Yes. So thank you very much for such a detailed review of systematic reviews. I have just a little question about the inclusion criteria. But for example, when we formulate a research question, so in inclusion criteria, is it all right that we are pre-specifying the types of studies which we are included? Like, for example, I would like to say that, for example, I'm making a research question and I'm just saying that, okay, I will do meta-analysis of only randomized controlled trials. And I'm just writing in the inclusion criteria that I have selected only randomized controlled trials and rest of studies I'm just excluding.
Yeah, that's very good question. Another good question.
Yes.
Say, for example, if you are trying to look at the efficacy of something, some intervention, it could be drug or something, then you already know that this is very clinical trials. Then obviously one of your inclusion criteria should be RCTs. And the experimental study could be randomized and non-randomized. And I mean, whole discussion is about the risk of bias. So if you really want to generate top level evidence that we know in randomized control trial is the gold standard, and that should be double blinded, that could be your another inclusion criteria. For example, in my review, if there is a open label that must be excluded, if it's single blind, that should be excluded. Only double blind should be our inclusion, right? And if you are doing, for example, our review was limited to 1990 to 2019, is because on this topic there is no randomized control trial before 1990. So there are a lot of other issues that you can, that comes from your clinical expertise or your topic expertise. So you can, I will discuss a little bit more later, okay?
Thank you very much, thank you.
Okay, if this is all, there is no question, we can talk anytime. If there is no question, we can go to Rajia, I think, for next step. Thank you.
Yeah, you need to move the slide.
Yeah, thank you, Rakib. So thanks a lot for these questions, because I think we learn more from questions than from us just saying things. So, and if you have questions during the session, feel free to write on chat, because we are checking the chat very constantly. So we've talked a lot about systematic reviews, but there's some problems with that. So, so when you conduct a systematic review, so we have told about every systematic and methodological process that it follows. But then once you start doing it, it becomes very difficult. So those of you who have conducted systematic review, can you raise your hands? I want to just kind of estimate the head count. Because learning about it and doing it are really two different things.
I was part of a systematic review project, which was really bad. I would say that's the only project I did, and it was like 10 years ago.
I have done systematic review of case reports.
Case reports, okay. And when Rakib said that I am not an expert, and then Joel said that he has been doing that.
No, I will. Don't worry, I will go for that. You cannot do a case report, because case report itself is highly biased and does not provide anything.
Exactly.
And I will tell a little bit more. This is case report is only used for hypothesis generation. Okay.
Yeah, so so Joel said that Rakib has 10 years of experience conducting systematic reviews, and he's calling himself not an expert. So I don't think you can ever get an expert in systematic reviews.
It's huge. Huge.
Yeah, It's huge, and you encounter so many issues when you start conducting one. So I would highly recommend that don't just get the training, but actually try to get involved in reviews and start doing it. So so some problems that it vary in quality, I think we have discussed this point a bit. So for example, RCTs, we say that they are the highest quality. But then there are other study designs as well. Even RCTs, they're not always the highest quality. Like Rakib mentioned that even there are types in RCTs, if they're double blind or not. So even in a single design, you will see a variety of quality, and quality also varies along the time. So in past, when there were less guidance, so there were less, the quality was also inferior. So when we include the studies, so we really need to do the critical quality assessment to really know that what we are doing, the quality of results that it's producing, we need to tell that what the quality is. And then it requires updating. Systematic reviews, they become outdated in 2 years. These days, the publications are massive, exponentially increasing. So in fact, by the time you publish, because it takes around a year to conduct a review and then around a year to get it published, by the time it is published, it is often outdated already. So this is a very big problem. And then may not include all studies. So if we only know English, we do not have resources to translate to translate the other languages to English. So we cannot include those, which is again which would cause bias, which will bias our results. And then might not include all gray literature and or the early literature. I'm just looking at the comments in the chats. Okay, don't have it. We shouldn't select OR during data extraction. Is not it. OR we cannot really meta-analyze. So we can extract it, but not something that we can really use. Sometimes we use it. So if we want to know, if we do not want to know the exact estimate, but we want to know whether or not it's favoring the outcome or not. So we sometimes say that the OR is favoring the outcome significantly or not. So this is a narrative for meta-analysis. OR, it's not helpful. And then quality assessment can be subjective. Yes, for the same review, if I'm doing the assessment, I might say that this is high quality. Rakib would say, no, this is low quality. So it is sometimes subjective. And so we recommend that there should at least be 2 people doing all the stages of systematic reviews. And then whatever we do, whatever we decide is based on the consensus or the third reviewer arbitration. So I and Rakib, if we do not agree with each other, Joel will come and say, okay, I think this should be the right thing, and this is my justification. So that's how the whole process takes place. Systematic reviews can be of RCTs or interventional. We have discussed that, or observational studies. So example, exercise after a stroke. So after a stroke, what's the effect of exercise? This is something that is an interventional. I mean, that is best answered in an interventional study. And then regarding observational, so there are times that we cannot conduct an RCT even if we want to. Can you give an example when we cannot conduct an RCT? Anyone? Any example?
What you're saying? Is there any question?
So the question is that give an example of when you cannot conduct an RCT. So the
potential
review
harm to patients.
Well, I mean, in many exposure is really harmful. You cannot do RCT. For example, if it's a prior knowledge that it's a simple example is the smoking, right? So smoking is already now established is the cause of lung cancer. So that could be done through observational studies, that is longitudinal cohort studies, but you cannot do that in a randomized control trial to one group. You suggest for smoking, as you know, these people are going to die, and another group, a placebo looking like, cigarette. So in that case, you cannot do randomized control trial. Okay.
Yes. Thank you so
Okay,
much.
if for example, we are conducting a systematic review and we are just searching the literature and we didn't find any RCT, any observational study, we don't find anything except few case reports about that association, you can say, or a side effect. So can we still conduct systematic review according to the PRISMA guidelines? For example, I've researched the PubMed, I've searched each and every database. I didn't find any RCT, didn't find any observational study, didn't even find a review article, but I just got like 5 to 10 case reports about that rare association or a side effect of a drug. So can
Yes.
I make a systematic review?
That's a great
Yeah, I think,
finding. That's a great
Yes.
finding to publish.
yeah,
So-
I think
Yes.
that's a very good finding. That's
Yeah.
a good understanding and good finding. Some people might feel that when there is no study and finding is really negative or something is not good. But this is when you say there is no studies in these areas, then this
Yes.
is a very good finding. But that could not be meta-analyzed. You can
Yes.
say that
Yes.
you should interpret
Exactly.
your result with caution, and that should be supported by risk of bias, because case series or case report actually kind of highly biased
Exactly.
evidence.
Exactly.
Yeah.
So in their inclusion criteria, what will I write? For example, should I write in the inclusion criteria that I've only selected case reports, or I should skip that?
Yeah,
In the
in this
inclusion.
case, there should not be very strong exclusion criteria, because you didn't know that, because your inclusion criteria should be very broad, because if you don't have prior knowledge, that should be very comprehensive, very open to get as much as evidence you can find from the database.
Okay. Thank you. Thank you.
But it's very hard to say very specific, inclusion criteria now, because I don't have expertise on that topic to say this should be the inclusion or exclusion criteria. I think you understand, right?
Thank you. Thank you.
All right, I think we can move forward to another slide. So I think, yes, we have discussed about the next slide was also about the study designs. Let's just move that forward. So Archie Cochrane, then back. Yeah. So when we talk about systematic reviews, we talk about Cochrane. Cochrane, they actually set the guidelines of systematic reviews. So so there was this scientist, epidemiologist, British epidemiologist, Archie Cochrane, and he was an advocate for RCTs to inform healthcare practices. So so on his name, we have this whole Cochrane collaboration, and they produce the gold standard reviews, and they set all the guidelines. But the Cochrane reviews, the focus is on interventions, but a lot of questions cannot be answered through an interventional study. So we have to do other studies, as Rakib mentioned, that if, for example, the exposure is harmful, we cannot do an RCT, or if even the question is not something that we can control. For example, if you're saying birth weight and IQ, so the effect of birth weight on IQ, so we cannot intervene on the birth weight. So these are some of the questions that can only be answered with observational studies. Next slide. Okay, how to do a systematic, we have discussed that a lot. Can you but then when you actually practically do it, we combine steps. We don't go step by step, but we combine steps. And there are two very important things that we do together. Rakib. So we define a question and we search the literature. We do that together. So we define a question and we search a literature. Why do we do that together? Rakib, can you please go back? Back. Yeah. Can anyone tell why do we have to do that together?
I think literature search help in improvising the research question.
Exactly. We cannot define the question without looking at the literature. So as Rakib mentioned, yes, to tweak the questions. And as Rakib also mentioned, so we have subject experts, but we rarely have subject experts for everything. So we have to do a very rigorous research on the topic in order to refine our question, formulate the question. So that's why these are the two things that we do together, plus the protocol. When we set the protocol, we need to have very specific answers that we need to decide before we even start conducting it. So we search the literature even before we define our question. So this is something very important for writing protocol. Next. And we assess the studies and put the findings into context. We should know that when we assess the studies, we should already know the context so that we could assess based on that before we could actually synthesize the evidence. Rakib? And these are the steps that we have already discussed, just that when we search, we have this, we have a lot of studies. So, and then in each stage, we narrow our included studies, and that's why it's a funnel shaped. So you'll find a lot of studies, then you would start with title and abstract screening. Some people do title screening first before abstract screening, but then it's recommended to do both together. So then generally we are left with just 10% of the studies from those we found in search, and then we further see the full text of those studies. Again, we would include 10% of those included in the title and abstract stage, and then even in the data extraction stage, we sometimes exclude studies because we might not find the relevant information once we dig deeper into the paper. And also in the quality appraisal, we sometimes just cannot include it because the quality was so bad, we got to know afterwards. So in each step, we actually narrow down or included studies before we synthesize the information. Next. So 3 main steps: planning, protocol stage, conducting, actually doing it, and reporting and dissemination, which is writing the manuscript and disseminate the findings. Next. Prisma is the statement that that is something you follow when you conduct a systematic review. The first statement was published in 2009, and then the recent one is 2020. So this is something that we have to follow when we are writing a systematic review. For protocol, we have Prisma P, and for the actual written manuscript, we have Prisma. Yeah, only Prisma. So this is the preferred reporting guidelines of how to write a systematic review and meta-analysis finding and how the flow should be. Next. So this is the checklist. So for each heading, we...
Sorry, I have a question here. I am Redwan.
Yeah, go ahead.
Thank you so much. You have said that the protocol is important. So my question is, if it is must to publish protocol before publishing the original of the systematic review. So what is the exact procedure?
Right. So I think Rakib has covered it a bit, but just to give you a very quick answer to that, it is not necessary to publish the protocol, but then it is always recommended to at least register your protocol. You can register, sorry?
Okay, carry on.
Yeah, so you can register it on Prospero, but then there are specific criteria of systematic reviews that you can register there, and you get to know a decision after, I think, 1 or 2 months that whether or not they're registering your protocol there. Otherwise, there are other databases like OSF, Open Science Framework. So so the protocol is actually it is for transparency. So if you're conducting a systematic review, I look at your systematic review, and then if I have questions regarding why you did this, so you need to be very transparent, that because that was in the protocol, because this is what we decided based on this justification. So this, have you heard of this term selective reporting? So
yes. Previously, I used STROBE, that strobe guideline of
strobe
the
guideline.
reporting. Yes, I followed it
different,
one of my publications.
Redonal, that's different. Strobe guideline is for reporting style for observational studies.
Yes, sir. I have used it in one of my cross-sectional publication, cross-sectional thesis, which I published later. That's what I had said. Then, sir, I have another question, please. In a systematic review, is it, for example, for me, I am a public health MPH student of Bangladesh, and my previous background is a physiotherapist. So in the area of rehabilitation, if I would like to publish a systematic review in journal, so is it okay to have the level of expertise that I have to write a systematic review? For example, in the topic of the elderly population, elderly rehabilitation, or fracture or something like that, or in other areas. But my question is there any bindings that you have to be a PhD or something like that, or professorship to be a systematic reviewer or in a manuscript or something like that? I know this
No.
might be a naive question, but I'd be happy to hear from you.
So all questions are really good. In terms of expertise, it really does not matter what your qualification is. You can conduct a systematic review during your, I mean, I know a lot of students, even we have them here, who conduct systematic reviews while they're studying. So they are but you're right in terms of methodology and everything. So you need to be very robust. Are a student, a bachelor student, and you might not have that level, so you need to actually collaborate with a research team to be able to conduct a robust systematic review, because the methodology needs to be very robust. Otherwise, you might end up with a systematic review that is not very useful. So you can be involved if you know you can be a bachelor student and you can have all the understanding of your topic and the methodology in.
I think I can. Redwan,
Sorry, I think I just dropped off. Can you all hear me?
Yes.
Can I add something just very quickly, Redwan? I think what you said, that whether you have skills to do that. Actually, whether you have skill or not, that nobody can say. So this is you. But there is a guideline. This is not about the qualification, educational qualification, that you are master's student or graduate student or having PhD or postdoc or professor. There are many professors in Bangladesh. They never go through this systematic process. So it's not about the age or it's not about the degree. It's about the systematic approach and skills. If you feel that you got that skills both by content and methodology, you are super to go.
Oh, thank you, sir. Thank you so much. Okay, sir. I understand.
Okay. Can we go ahead? Rakib? I'm audible, right?
Yes.
Yes.
We are.
Hello.
Yeah, I can hear
All
you.
right.
Just a little bit breaking.
Let me rejoin. Rakib, can you please cover this one? I'll just rejoin because I think there's a problem with the connection.
Sure. So this is the Prisma checklist. All right. So you can see that previous studies included, and this is suggested that Prisma guideline. This is the Prisma actually diagram, and each step what you are doing. So here you can see I can't see that one. You can see the database identified from database, records identified from databases. So it is advised that you list N for each database, not like this. So say Medline is 200, Embase 220, PsycInfo 300 or something, other database, something like that. And then you can get some records from other website or organization or Google search. Then you combine those together, and then you remove duplicates from your reference manager or from Covidence. And then you go for full text review, and then you get your final included studies. And I think this diagram is a little bit complex. I will show you later the more clean version that will be easy for you to follow. And formulating the review question that I think already we discussed. The importance of review question. A systematic review seeks to answer a clear, explicit, and unambiguous question. So this is really, I think, everybody understand what does this importance of review question, because if your research question is not clear, then you are not going to answer that question. Right? Then how do you convert a free form question into well-structured free form question, well-structured review question?
Rakib, sorry to interrupt. Like, I want to add something on the previous slide.
Yeah.
Okay, so here you already know about research design and how to develop a research question. But see, for systematic review, we are already including established or published research, which already have well-formulated research question. So here, why it's important? Because like one important thing is in systematic review, research question related to systematic review, obviously it's gonna be well formulated, but usually we don't do any repeat research question, or we don't answer any I will say no repetition of a research question or systematic review. So that's why this is unique. For example, in empirical research or original research or primary research, if you have already some research there or published, still you can do some research which could be like almost similar in terms of reproducibility, or maybe with better evidence and other thing. But when we are doing a systematic review, if something is already done on that particular research question, it's already answered, you can only update that from that point. Otherwise you cannot do another repetition or similar systematic review on the same research question. So that's thing I think you should also keep in mind. That's all.
I think, well, are we going slow? I mean, for participants, how many hours already gone? Whether they are interested to keep continue, because it's still half of them are not covered, I think. So,
yeah, I think we can go quick a bit, and we have like at 1 we'll have a break for 1 hour like prayer and lunch break. So you can go ahead.
So how do you convert a free form questions into well-structured review questions? So this is actually, I would say, more about Razia, do you
Ranjit
want
is
to say
here.
something?
I think she can take over.
Oh yeah, I'm so sorry about the
That's fine.
connection issue. Okay, this is a question for you all. We have talked a lot about formulation of a question and the criteria, the eligibility criteria. So this is a question that I have. What is the impact of stress reduction interventions in the workplace? So I want to ask you, what's the population in this study?
Those who are employed in any institution.
Yes. So we said
Workplace.
workplace. So workplace is the
Yes.
key. So the employees. Intervention. What's the intervention here?
So you probably have
Stress
don't know.
reduction.
stress reduction
The
strategy or
reduction
policy.
techniques.
Yes.
Right.
Stress
Yeah,
reduction.
stress
Well,
reduction.
yeah, the intervention that we decide to reduce the stress. So it could be anything, for example, breathing exercise or meditation, any kind of intervention that we decide is actually the intervention. So comparator, it could be anything. The comparator, we could compare it with nothing. We can compare it with a similar thing with a lower intensity. So for example, we are comparing a meditation plus breathing exercise with only breathing exercise. So in that case, only breathing exercise will be our comparator. The outcome, what's the outcome in this?
Reduction in stress level.
Outcome is
Yeah.
the impact. Impact.
Uh,
Impact is the outcome.
I would say it's still vague, like the impact. What do you mean by
Yes,
impact,
yes.
right? It's still vague.
Exactly.
Right. So stress reduction is actually your outcome. And whether it's reducing or increasing, this is something that we will know after we conduct a systematic review. So we'll focus on the stress reduction as our outcome. So study type, study setting, if it's an interventional study, what do you think the type would be?
I think you're going to include randomized controlled trials or maybe quasi-experimental studies,
Yes,
interventional studies probably.
perfect. Can you move the slide, Rakib? Next slide. Next. So we have identified that population is our employees. But when we say population, we just don't say employees. We need to specify what is the age group that we're targeting, employees, which employees. There's so many industries. So what's the profession that we are targeting? What's the work, what's their work pattern? Because that could very much differ in, for example, a doctor who is working 24/7 compared to someone who's working in office. So what's their work pattern? So these are a few things that we need to specify if we have to formulate a well-refined question. The second are the intervention. Those could be training programs, well-being programs, health promotion. So again, we have to specify more that what could be the type and how they have delivered it. Are they delivering it alone or with combination of others? So we can take multiple interventions, multiple level of interventions as well. But this is all something we need to specify at the protocol level, that what we are looking at. Next, Omer, that what? Yeah, you can ask.
I just got a quick question. So I wanted to ask, like, if you are going to specify all this information at the while you're formulating your research question, I know that it's going to be very specific research question, which is obviously very good, but don't you think this is some information that you should come up as a finding in the systematic analysis? For instance, you may suggest that the training programs were more effective in those who are working in a specific setting, or probably those who were aged like 50 above, or maybe those who were like in the middle age group. So I think then you can come up with more interesting and enriched findings.
Right.
Just a thought.
So what you're saying is finding, but to have that finding, we need to decide what is something that we're including. So you said that if we come up with that this training program is beneficial for this age group. So in protocol stage, we need to decide that what really is the age group that we are targeting. It could be a broader age group. It could be a narrower age group. And then we can come up with, and if you select like multiple interventions, and then we try to see that which intervention is beneficial for which age group. So so what I'm trying to say is we need to have the set criteria that this is the age group that we are targeting. We can't say that we will also look at an infant. Infant is not really applicable in this case. We will also,
can I help Alia to answer this question? I think it's
Yeah.
what you said, that is a kind of preemptive. Okay, what you said is preemptive, but what Alia is saying that, you know, is a kind of protocol. So you just don't know what has been going on, but what you can do, you can guess, or you can just hypothesize that this could be different in different age groups. So that should be part of your protocol as sensitivity analysis or subgroup analysis. So when you are developing protocol, you will write those. But what should be the outcome, you cannot say prior. If you say prior, then this is really preemptive results. So there is no point of doing systematic review there. I think that's it.
so yeah.
Sir.
Thank you, Rakib.
Sir, may I ask a quick question, please?
Yeah, sure. Go ahead.
Okay, sir. My question is, here is we are looking for intervention of the studies. So in such cases, we are not likely to include the observational type of the studies, or let's say the non-intervention of the studies, or is it the complete the liberation of the researcher, or that he will include the observation studies or non-observation studies? So,
of course, you have the liberty, but it's depending on your research question. If it's really you want to look at the intervention, like the example here, maybe randomized control trial is not going to be effective way, maybe quasi-experimental, because it's not going to be double-blinded like drug intervention. So it should be quasi-experimental, or it should be open-level, non-randomized maybe. So it's depending what kind of your research question you are going to answer.
Thank you, sir. So it would depend on my research question about the type of type of the article we are looking for. Okay, I understand.
And I would reiterate again what Rakib said before regarding efficacy. If our question is efficacy, we cannot include observational studies.
Exactly.
So, yeah. So it all depends on what question we decide. Next. Comparator could be anything we have discussed. It could be social support programs delivered outside the workplace, or nothing, or even a lower intensity program. An outcome is the health and well-being of employer, cost and time of health and well-being of employee, and cost and time of employer. These could be the outcomes, or there are other outcomes that we can include in this research question. So all of it we need to identify, we need to specify at our protocol level. That's what we are interested in. Okay, next. Is it always necessary to have a comparator? Again, depending upon the research question. So if we are including interventional studies, yes, it is important to have a comparison. But if we are including observational studies, for example, there are comparison in some cases and there are no comparison in other cases, depending upon the research questions. For example, I want to know what's the prevalence of diabetes in South Asia. So can you identify a comparator here?
No.
So yeah, so if we are looking at such questions which are where we cannot have comparator, I mean, in our question we can add a comparator, but if we just want to know a prevalence of one place, we will not have a comparator. Next slide. So we have talked a lot about PICO's criteria, which is population, intervention, comparator, outcome, but then there are so many framework depending upon the question. Again, oh, so this actually answers your question about comparator. It's not necessary to have a comparison. We can have other framework depending upon what the question is. There's this COCOPOP, which is condition, context, population, and PEO, which is population, exposure, interest, outcome. So PICOT is again one very very much used framework. It's used in very high quality observational studies like population, intervention, or exposure. So if you're not intervening, but if we are looking at levels of exposures, we will have comparators, but we cannot intervene those. For example, if I want to check the association of pollution on health outcomes. So pollution, pollution on health outcomes, and so in that case, we can have different locations where the exposure level is different. We are not intervening because pollution is something occurring very naturally. So in that case, we will have population, we will have comparator, we will have the outcome and the study type, but we will not have intervention. Instead, we will have the exposure. So yeah, next slide. End of slide. Okay. Now we will move towards the search. So how actually formulating the search strategy. Let me share my screen.
Yeah, I think you can ask for if there is any question before going for direct.
Yes, please.
And Rakib Bhai, did you make Razia co-host? I think then she can share.
I can share, I think.
Okay, that's great. That means you're co-host. Oh, yeah, you don't need to.
Is there any question, guys?
Okay, that's fantastic that you guys don't have any question anymore. Razia, please go ahead with the application part. So now we are moving to our second part, application of all those things we have discussed from the from our morning session, and then after lunch break, we'll have our meta-analysis.
If you guys feel comfortable to ask in Bengali, fine as well. Don't feel that.
Yeah, Shormisha, do you have a question? Shormisha?
Yes. Thanks for the opportunity. Well, I do have a very naive question. Like, if on a specific research question, if already a systematic review has been done and published, but maybe it has been done 5 or 10 years ago, and then after a certain period of time when multiple number of new research articles on the same topics have been already published, and during data extraction a lot of new articles or manuscripts are available, then is it okay, or is it advised to do a systematic review on that topic again after a certain period of time?
Yeah,
that's great. Yeah, that's what I mentioned earlier, like when Dr. Rakib was talking about formulation of research question, the extra note I added that if you think there are sufficient studies which are not included in the previous studies, and some time passed like 5 or 10 years, then you can update that, start from that systematic review. So it's okay.
Thank you.
The important thing is that it's called updating systematic reviews. note that there is no specific time frame to update systematic review. Is depending on the topic. For example, if you are working on diabetes, then maybe you need to update every 2 years, because by 2 years will be huge number of publications, right? But if I am working like in our review, that testosterone and sexual function, and it is pretty clear next 10 years is going to add maybe max 2 number of studies or 3 studies, even less than that. So in that case, you can again update, or you can just provide a very brief, summary if your original review is really not consistent with the update, results. But if it's not changing anything, then there is no point of doing update. Does that make sense?
Yeah. Yes. Thank you.
Okay. I have some additional points to ask, please, if you allow.
Yeah,
on
please
this
go
topic.
ahead quickly.
Yes. Okay. Then, if so, based on your discussion, we can assume that we should have some insights to the systematic review, whether or not if the review is going to add something in the literature. As already there are some systematic review have already been existed in the literature.
I think the question is that whether we need to update, and the other question is that if there is systematic review, we should not do another review. Only the systematic review done by a group, they can go for updating, not other people going for that. Other people can do that, but it's because there is no kind of regulation that if I do systematic review, then you cannot do that. But the question is that whether you have that kind of expertise. If not, then let the other group who did earlier to do this update again. But if there is a similar kind of systematic reviews, then I would advise not to do any systematic reviews further.
We can change or alter the topic a little bit. For example, a systematic review has been done with the experimental type of the studies, then we can go forward the observation studies or something like that.
That I will discuss later. I think it's a understanding of the evidence. So for example, if a study is published based on randomized control trial, then there is completely no make sense of doing observation systematic reviews based on observational studies, because that provide always very, very low level of evidence that I will discuss with the evidence-based pyramid later. Okay.
Thank you, sir. Okay.
So I see a lot of interest regarding systematic review update. So I actually had been working on a review regarding the automated tools that are available, and I will show some of them to you. And at times you're not sure whether there are more studies in this topic. So there are a few tools that help with that. So you can always see what are the recent studies in this subject matter, and then you can decide whether or not an update is required. There's another concept of living evidence in application. It has now been it has been in discussion for like, I think 5-6 years, and living evidence is something to update systematic reviews in real time. So because as I mentioned in the problem of systematic review is that it gets outdated very quickly. So now there is one software that helps in this, but I'm not sure how efficient it is because all of this has been in discussion for very long and the application has just started now. So there's one called Nested Knowledge. And what it does is, so you formulate a search strategy and then you have it in this database. And this is actually this software, and this software actually helps in the whole process of systematic review. And it updates the search, and it gives the new studies after every month or so regarding the topic, so we know that how many studies are there. So this then produces a living evidence, living systematic review that is updated in real time. So these are the discussions that have been going on in this topic, in this update theme. So hopefully
Can
we
I
will
add
have
little bit
something.
Ria, here about living evidence?
Mhm.
Living evidence is really, as Razia said a few years back, it was really, people thought that it's not possible to do that due to lack of resources. So during the COVID-19, that come up very strongly. And I had the opportunity to be involved in the first evidence-based task force. It's the first global evidence-based task force that led by Australian Cochrane Group. And I was a part of that group first 6 months of COVID-19 here in Melbourne. And that has been actually used a huge number of people and organization in that task force. And we first time I'm named in a methodological paper, and we showed first time this is feasible, and it's as you said that how long, it's monthly or bi-monthly, but since COVID-19 was so devastating, our evidence guideline is updated every week. Now it's I can't remember, but it's across the world, it's millions of clinical practitioners are using that guideline, and now it has been about 2 years and it's still continuing. And every week there is a huge, more than 100 people involved in evidence synthesis. So from database search to robust evidence generation. So you can see evidence-based guideline and the Covidence, Australia Covidence, the Covidence team is really based on Australian Cochrane Group. So you can see it's a huge people involved and huge funding from US as well as from Australian National Medical Research Council and from UK. So this is possible, but it's really demands huge resources, which is really often not possible by a single organization or a group of people. Thank you.
Thanks, Rakib. And I'm so impressed that you were involved in such a groundbreaking thing. So this was a concept that actually my CEO, he came up with. So he was the first one who wrote this paper on living evidence. And then now they are working on really making it possible. Yeah, so it was, it received a lot of attention during COVID-19. And then as Rakib mentioned, this database that updates weekly. So this was a concept that just came up, but now it is in application, and hopefully we will have in future. It does require a lot of resources, but there are teams working on really making it a reality for all the topics. It will take a lot of time, but it will happen someday, hopefully. Okay, can we go next? I think we are very much short on time. Rakib, oh, sorry, it's me.
Yeah, Radhia, you're sharing.
Sorry. So we have already talked about the steps of systematic review. Now we are in the fourth step, which is search for studies. And so there are two main types of studies. One are the peer-reviewed literature, and other is the gray literature. Since we say that we need to include everything in a systematic, it's good to include whatever information we have in a systematic review. So we also search for gray literature. Peer review, I see a lot of researchers in this group, so I don't have to really explain it, but peer review is something that is peer review by an expert before it is published. So it is more it has more sound methodology, and we can rely on those peer review literature. Again, in peer reviewing, it also depends on the journals and who is actually the peer reviewer. So, but then again, peer review literature are more reliable than the gray literature, because those are the literature that's not formally published. And it could be reports, fact sheets, white papers, conference proceedings, other documents from various organizations and government agencies. Sources of search. So there are many databases. We generally go from the most the databases that have higher quality, like Cochrane Central and Medline, Embase. We start from here, and then we go towards unpublished and or ongoing studies. And these are some of this is one resource where you can see that if whatever systematic review you're doing, whichever domain it is, you can check what are the journals available from where you can search for data. So I would like to show this one. Please let me know if you can see the screen. Can you view the screen?
I think you need to switch, or
Yeah.
maybe share your full screen.
Yes.
Yeah.
I think it's okay. We can see it, and it's fine.
You
There's a
can see
presentation mode.
you can see the Google Chrome screen or the presentation.
No,
We
presentation.
cannot.
You need to share the
Presentation.
Google Chrome.
Maybe you can paste the link in the chat box and we can open on our own.
That is
No,
possible.
she needs to show like exactly how we will start. That's what we are trying to do. So Razia, you need to just switch the screen.
Yes, I'm
Or
doing
share the whole Windows or
that. Okay, now can you see the screen?
perfecto.
Okay, so this is a John Hopkins library where you can select the domain, and then it will tell you the journals that you can search, even in the domain. So these are so many databases that can be searched.
Razia, why we're looking at journal databases?
Yeah, these are actually the journals.
All
Wait.
databases, yeah. Click on that.
Hmm.
Should I share Monashon?
Sorry,
Should I share Monashon to?
Monashwan?
Yeah.
Yeah, sure.
Okay. Very quickly. And then you can start.
Are you sharing your screen?
Yeah. Yeah, you can see, guys, the library and database. Can you see?
Yes, we can.
Yeah. So you can see that quick link, that Ovid Medline, that is one of the most popular. And other way you can look at by alphabet. So if you click on, say, Embase, if you click E, then you can get, if you scroll down, and you will get a lot of databases, but it's you need to search those are really relevant for your subject. Like if you are from commerce background or social science background or engineering background, then your database could be quite different. But if you are, economics, then you can see there are different databases here. But we actually use that Embase one, which is you can see embeds by Ovid Medline. And also you can go by specific subject, database by subject. Yeah. So another is that, like, say, if you want to search site info, then if you click there, then you can go a little bit down. ProQuest also sometimes people use, and you can also get clear, explanation what kind of data actually stored or indexed in these databases. That's also a good way to, yeah, you can see site info.
Do share the link in the chat so everyone could have the access to this.
I don't think so. They can.
Oh,
they can log into Monash without logging into Monash. I don't think so.
Sir, I have another query. Sorry, maybe I'm asking too many questions.
No, that's fine.
Okay, sir. Thank you, sir. In Bangladesh, as you know, both of you are Bangladeshi, we don't have enough access opportunities. In such case, for example, a few days ago, I was doing a literature search and I cannot download some of the Elsevier articles that are published in 2022. So if we do when we would like to do any systematic review, the thing I assume is that we have to go for an extensive search, but it is not possible from Bangladesh to get all of the Elsevier article access or something like that.
Yeah, that I mentioned before that if you are not able to do that, you have to collaborate with other people who have access to these databases. Otherwise, you cannot generate any evidence, which is really very problematic for policy implication or clinical practice.
If I add with something with Dr. Rakib about your question, so we have already talked a bit about this. So systematic review, you need to have this access to this data set. That's a kind of precondition. And if you don't have, you have some available, like you go for Google Scholar, JSTOR, Science Direct, and then PubMed One. Those are kind of free and freely available, accessible. But with those, you cannot do comprehensive like searching for systematic review and meta-analysis. You will see lots of paper. They have just used maybe Google Scholar, PubMed, and JSTOR, those things. But that's also kind of limitation of that systematic review, that this is not the quality systematic review or not the comprehensive one. You can just based on that. So that's why we want that, okay, so if you're really interested to conduct the systematic review, particularly the people in Bangladesh, so you should talk to your librarian in the university. They have access to this database. Okay, maybe you don't have, but they have those access. And if you don't get that access through the university, you need to collaborate with people who has access to those comprehensive databases. Okay, so that's why for conducting any systematic review for comprehensive search, collaborate with librarian, talk to your university or like library for access, or collaborate with like a scholar or researcher.
Foreign institutes. Okay. Collaborate with the foreign institute, those who have the access. Okay, thank you so much, sir.
Yeah.
Thank you so much.
Can I ask you a quick question before I leave, because this is really midnight, not midnight.
I know it's too late. Sorry.
Early morning in my part of the world. So I'm sorry, Rakib Bhai and Joel, I missed some part of it because of, just it's early morning.
Yeah, I really wanted you to be like during the meta-analysis part.
I'm trying to get another mug of coffee, strong coffee, so that I can stay awake.
Yeah.
Sorry, the quick question I had about like search strategies. I know Rakib bhai probably have covered it. I just missed it.
No,
Do you
not done yet.
oh,
Database,
you're not there. You're not there yet.
no, database search has not been done yet, but what I did for SAST long before, I think, there is a complete database literature search kind of video, or I did long before, I think a couple of years before, but now we didn't do any systematic database search. And Razia is going to do that.
Oh, I'm sorry. Then I'm probably not going to ask that question. Go ahead.
Yeah, Razia, please go ahead.
All right, so I'm audible, right?
Yes.
Great. I'll quickly move towards the application of search, how to build the search strategy, what are some of the elements and everything. So just before that, Medline is the most popular one. So we are all here from the field of medicine. So this is the most popular database that is searched, and it covers the fields of medicine, nursing, dentistry, veterinary medicine, the healthcare system, clinical science, and there's much of the literature in biology, biochemistry, molecular evaluation. So how do we access it? So there are two ways to access it. Everyone would have access to PubMed. This is a free search engine, which is although not recommended, but and so it's recommended. So if you do not have the access to Ovid, which is the licensed one, it requires a subscription. It's recommended that you collaborate with the people who have the access. But then there are many people who just use PubMed. So you can use both, but Ovid is recommended. It's a systematic approach to searching. For this, you will need to see this protocol that has been sent to everyone during the registration. So this is a protocol of a study, a groundbreaking study that Rakib did. And so we will use this study in order to build our search strategy. So it is regarding the effects of testosterone therapy for women. Rakib has already mentioned a bit about it. So in this study, I just want to ask, what do you think are the PICOs? What's the population in the study? Anyone?
Broadly women.
Broadly women, right. So yeah, I'm just asking broadly. Sorry. Right. Why can't I move back? Okay, and what's the intervention?
The testosterone therapy.
Yes, and comparator.
Razia, we cannot see.
Yeah. I'm again sharing it, but
no. I mean, this is helpful because I can stay awake because I'm answering your question. Sorry. What was your question?
So my question is, the study that was provided, this one, what's the comparator?
I see the comparison group. Okay. Probably those who didn't have that therapy.
Okay.
I said probably.
No, I think for all guys, that's really very good, Razia, you started with, because it will be very helpful for my presentation when people understand that.
Yeah, everyone just should follow this carefully, because we are starting our study from search to meta-analysis. You will see and you will apply in this class or session. Okay.
So yes, please do be attentive here. And so actually I will not be doing a lot of things. You'll have to tell me everything. So and you already have the resource, you already have the protocol, so it's up to you. You can see from the protocol and tell, or you can just guess.
Ravi Tariq said control group is with no therapy. or any alternative therapy. Fantastic. It could be different combination of therapy.
Exactly.
Yeah.
Fantastic.
Thank you. And the outcome here?
And there are many that I can see a range of outcomes, including sexual function and some cardiovascular events, metabolic parameters, musculoskeletal health, well-being, cancer events, androgenic effects, and withdrawal rates.
Great.
Awesome.
Well,
Awesome.
it's really every outcome, possible outcome.
Rakib Bhai, I had a quick question regarding that outcome. So I see sometimes in the systematic review, people don't put like the outcomes per se. It's like implied, right?
Mhm.
Like in the title, I'm talking about in the title.
Okay.
Is it a norm like?
Yeah, that's very comprehensive. That's why, I mean, this is the comprehensive review people ever do, because that's why it's no specific outcome, but most likely people really concentrate on sexual function, but there are a lot of other secondary outcomes that's really harms as well as adverse effects. That's why it's open. Testosterone therapy, when people are giving testosterone therapy for any kind of outcome, if testosterone therapy and sexual function, that should be included. If testosterone therapy and cardiovascular disease should be included. If testosterone therapy and musculoskeletal health, then should be included. If testosterone and psychological well-being and depression, that means it's open, but it's listed all other outcomes later.
So you mean
Okay,
if you, sorry to interrupt. So you mean if you have any specific outcome that you would like to focus on, then you have to mention that in the title?
Exactly, because if we put all outcomes here in the title, then you can feel whether this should be title or it should be a text or paragraph.
No, I understand completely. I understand completely. Like, let's say I'm not quite sure. I'm studying like the impact of some intervention on health, right? But what do you mean by health? Like health could be physical health, mental health, or within physical. Yeah.
Yeah, that's really very vague, because health could be any kind of health. Then you need to be very specific. But but when we are saying, because it's compared to the example you say, that intervention for health is really vague in terms of both exposure and outcome, right? But here, when you say effects of testosterone therapy, that actually given a kind of very precise reaction for women's health.
Yes.
Well, can research question be, excuse me, can research question be just like simply like that? For example, I'm just doing a systematic review and meta-analysis of efficacy of any chemotherapy drug. I'm just writing like, for example, efficacy of let's suppose bevacizumab, efficacy and safety of bevacizumab, systematic review and meta-analysis. Can that be a research question?
It could be, but it will be very hard to handle that later, because it's
it will be broad
therapies, and it cannot.
Yes.
And against each therapy, there are a lot of outcomes, so you cannot afford that, right?
But it can be.
Yeah, it can be. It can be.
Yes.
But you need to disseminate information to the clinicians. But if it's lost, then it's a problem.
Okay. Thank you.
All right. Let's move forward. So when we formulate a search strategy, we do not take all the components. We take just 2 or 3 important concepts. So, for example, in this case, in interventional studies, we generally take 3 components. First are the participants, second, the intervention, and the third study design. So you can always use the filters for study design. So here in this case, participants would be women and the intervention would be testosterone therapy. So, so these are the two concepts that we will take forward for formulating the search strategy. In outcomes, in observational studies, outcomes could be more important. So we do a lot of times, or I would say most of the times, we include outcomes in formulating the search strategy when we are looking at observational studies. Now, there are two types of searching. One are the keyword search, and the other is the mesh terms. So keyword search is, so in an article, if we have written women, so if you're typing women, then it should match exactly. And then it may miss alternate terms. So for example, if women are also denoted as females, it would miss that. So we need to write female as well, and often results in more false hits. So it happens because in keywords, so women is a very general term, so we will have a lot of false hits. So we need to really see the sensitivity and specificity of the search strategy before we actually finalize it. And then mesh subject headings are basically the concepts. So these are the systematic keyword catalog, which in which the results match the concept of that term. So it is mesh in PubMed and Emtree on Scopus. Scopus is another very popular database. So it improves the precision and saves time, and it's good for well-defined topics. So if women is a mesh term, then this women will include females as well, because it's based on concepts, not the keywords. So this is the difference. Keywords is exact match, and mesh terms, the concepts. And there are very well-defined mesh headings that we need to, we'll talk about it. We can find it through PubMed, and there are other automated tools that help in this. So, but then, yeah, so how to find keywords. But before finding the keywords, we need to know how much do we know about the topic. Because if you're saying testosterone therapy for women, what kind of women are we talking about? We don't know. So we need to first see the literature. What kind of women use the testosterone therapy? What's their age group? Or is there any other concept that we need to take into account while we are while we want to synthesize the evidence on the therapy on women? Like, are there any specific kind of women who use that? So these are some of the concepts that we need to know. So there is this very generic database, Open Knowledge Map. So here what you can do is you can, when you do not know a lot about the topic, you can always write the two key terms here. For example, therapy and women. So what the database does is it will create a knowledge map. So within this topic, it will tell that what are the different kind of studies. If you select one kind of a study, for example, if we say that this one is probably relevant, so it will tell all other kind of studies, and then we can use, this is one of the resources to kind of search for different studies. So it has knowledge maps of all the concepts regarding these two, the papers regarding these two concepts. And then if we dig deeper into this, then it will tell the similar paper regarding regarding the papers that we select. So this is how it works. And then there is this tool, Insightful. I'm just showing briefly because you can always use those for your reviews. Okay, so this is one of the tools that is very helpful in telling characteristics. If we have one study that we know should be included in our review, so it helps in, for example, in this review, I identified one of the studies, this one. So before the review, you should know a few relevant studies. You need to search for them before. So you can simply search for this study, and this is the one. So it gives similar papers regarding the study. It gives a map that these are the studies and how they are related with each other. And so you can always save these studies as well. And the other things that are helpful are some of the important papers in this area. And yes, recent papers are very, so this is again, also this comes to the point of update. We can always check the study and see what are the recent papers. So we can use this in deciding whether or not an update is needed. So for now, what I'll do is, these are the similar papers and I want to have them saved in my library. So I will save them as RIS, and you can open it up in your whichever database, whichever reference manager you're using. And Node is a recommended reference manager, but it is paid. So I am not focusing on EndNote much. Can you see Zotero?
Yeah.
Yes. This is the reference. So these are the references that I have imported from the Insightful database, which are of the similar studies. And then these are the studies that I can easily see from my library. I can look at the abstract, so it's just easier. So you have everything in one place, and then you can learn more about the keywords, the words that they have used, and also you can obviously read more about the topics to refine your question. The next thing that I want to mention is this one. So this is something we often struggle with, the keywords that are used, how to find the keywords. So this is one of the tool that helps in this. I'll drop the library that I just downloaded from where? From the Insightful. So these are some of the keywords that it is telling me. So I see some of the words like postmenopausal women, menopausal women, androgen. So so it just gives an idea that what kind of women are we talking about here. So obviously it involves digging deeper, but it gives an idea regarding what are the keywords, key terms that are mostly used in these studies. All right, so we have the, so first what we do, we try to find the relevant studies. Then we look at the relevant studies, we read about it, we see what kind of population are the have the studies included, and then we can use the tools to identify some of the key terms, and also we can use some of the previous similar reviews for that. So that's very helpful sometimes to look at the previous similar reviews to identify the terms that they used. Okay, so there are, this is very, one of the main things to remember, that there are some rules regarding keyword searching. So words appearing in the title or abstract of the record are used as in the keyword search, and they include synonym. So we need, if we are doing the keyword search, we need to include all the synonym. So if we are interested in brain injury, we need to we need to also type head injury, skull fracture, if we want the term exactly to, if we want to these terms to be included in our relevant list as well. And then truncation. So if you put an asterisk, it will give all the terms that can be made from that. For example, if we if we want to write the word protect, but we are also interested in term protective, we are also interested in terms protection. So we can just write protect and then asterisk, so it will find all the variations starting from the word protect. So it will include protects, it will include protective, it will include protection. But we really need to be careful. For example, if we want to have studies on cancer, carcinoma is one of the word. We cannot write car asterisk, that would include so many false hits like cars or I don't know others. So okay, this one. And then use wildcard. So in American and in British language, there are words that have variation in the middle. So for example, behavior. So it could be VIOUR or OR. So we can just write question mark and then R. So it will include both behavior and OR behavior and OUR behavior. And then this is something, this is used in very much advanced search, so which is proximity operators, near, next, adjacent. So if I want that liver could be in 3 places from cancers, within the 3 places from cancer. So if I want to include liver cancer plus I want to include liver and bowel cancer, so I can write liver adjacent 3, ADG3, and cancer.
Razia,
That would include all of it.
Razia, can you hear me?
Yes, I can.
Okay, I think like in Bangladesh, in Dhaka, now it's prayer time, so we need to go for the break. It's Juma.
Right, I think we can take a break and then we can move towards towards forming the search strategy for the paper that Rakib shared, that Joel shared and Rakib wrote. So all right, I think we can have a break for an hour.
Yeah, so maybe Mariam asked for a link, so you can send what's the link. And hello everyone, as we have shared that we are going for a break, so it's a prayer and lunch break. So we would request you to be like to rejoin within 1 hour, okay, because we have meta-analysis to learn, okay, and code in Stata and apply everything after the search. So we can go for a break now, and please rejoin within 1 hour. Thank you so much.
I'm sharing the links, but you can also find those in the presentation that will be shared.
Mr. Shofi Rahman, maybe you saw when we email you, we already shared 2 videos to install Stata. So yeah, that's one important thing. Everyone, please install Stata in your computer. So when you share email, maybe you saw there are 2 videos. Video instruction, it's in Bangla, that's an issue. So maybe some people who don't understand Bangla, they can just follow the instruction all alone and you can install it by yourself, okay? What sort of code, Shofi Rahman? Just follow the instruction through the video, okay? So
we're not going to give you a lot of codes because the analysis is really one line command, but the underlying learning is very important because you can get different kind of codes from
no, he's asking for code for Stata installment.
Oh yeah, okay, sorry.
Stata install, yeah, definitely that one like you will get it like as data code for that, but just follow the video instruction. You will follow the cursor and you can do this. I think most of the people already did, so please let me know if you did not install it yet, so then we can help. And Shafi Rahman, you can okay, that's good if you install. Any issue? Okay, you can share the screen. I can instruct you. Share your screen and show me. Rakib bhai, please stop recording. I think because it will be 1 hour break, so we can stop and then
Yes, actually, that's the most important.
you will take. Razia, how long do you need?
I need
Finish
so
your part.
I need to go through building search, and then I have to show the process in Covidence. So I think it will take about 30 minutes. I'll just try to be very quick.
Okay.
So okay, we will.
Yeah, we can finish. Yeah. Then Rakib bhai, I think 1 hour will be enough for you.
I will try. I can finish very quickly if you want, but it's depending how much you want to go.
I really want that people
Yeah, no, I
spend some time in meta-analysis because it's also very important.
Yeah, that's what I also want. And for your part, I'll say like rather than being more theoretical, if you can show quickly and then.
Yeah. So most part is basically just that. So in PubMed, you will see here that the sort of will come towards PubMed. First, the structure of a search strategy. So there are the concepts that we take, and then for each concept, we will have to find a synonym. So whatever the population, like I talked about, just gonna reiterate. If it's women, then we also are, then we'll also write female or all the synonym related to that. Determinant, synonym, outcome, synonym, and then we combined one concept with or, and then we combined between concept, we combined with and. So this is a table that is a good depiction of it. So we have three components here: population, determinant, and outcome. So for all the population terms, we will combine with or. For all the determinant terms, we'll combine with or. And for outcomes, we will again, for each concept, we'll combine with or. And for combining the concept, combining one concept with another, we will combine with an and. So again, this depiction is helpful. So if we are saying and, it means that.
From Jalal, I think.
Sorry?
There is question from.
Oh, I had a very quick. So like
Yeah.
these are the search strategies even for any reference management software, right?
For any software, yes.
For any like literature searching software.
Any
Okay.
software. So
Okay.
this is a generic one, but then there are further. We're not going to dig deep into each software, otherwise this will be massive. But again, there are tools now available to translate from one database to another. So
Right.
all right. So if our topic is hip fracture, so this circle is for hip, this circle is for fracture. If we are saying and, it means that we are so this is the target. So also the hip part and also the fracture part. If you're saying or, it means like renal or kidney. It means so renal and kidney are one concept, so we will combine it with an or. So it means that we are covering everything. And not, it means renal. Just a second, I have this distraction of. Oh, I'll just stop the video so I don't have this panel. I cannot see the. All right. Sorry. And then not is if we are interested in renal but not failure. So we will so the one that we write after not is the one that we are excluding. So sometimes if we want to exclude, for example, we are interested in observational studies. So there's also one kind of a search builder, which is related to reviews. So we can say not review, systematic, literature. So if we have to exclude one portion of the concept completely. So how to search in PubMed. We use advanced search in PubMed, and these are the fields. I'll show you all so that we have more idea on this. So you can see my Chrome, right?
Rajia, can you go for formal database only? If you're not going to show sources for all databases, right?
Sorry?
Are you going to show database source? I mean, all specific database sources or only one?
So only one. The reason I'm using PubMed, although it's not recommended, is because so Medline has two ways to search. One is Ovid, other is PubMed. So Ovid is licensed. So I really want that if I'm showing you, you also do it on your part so that you have an idea on how to go about. So therefore, I'm showing just the PubMed here. No, not all databases. We cannot cover everything in one session, but you will get an idea of it. So let's talk about the topic, this paper of testosterone therapy for women. So what's the population that we talked about?
Women.
Women, okay. What kind of women? Okay, first of all, okay, for women, I am writing, is it okay to write this, or is there an efficient way to do it? So do you remember the guidelines that I shared, the truncations and everything?
We can start.
We can?
Yeah, there is comment from Mariam. I think it's a very great, women integrative sign and N, that means covering both women and women, and also could be used women truncation. Yeah,
right. We can use truncation. So in this case, one appropriate truncation would be, what do you think about an asterisk? Is that helpful? I want someone else to speak now.
Yeah, it could be like women,
Yes, it might be them additional terms.
Sorry?
Yes, it is useful, I think, because additional terms can be included with this search.
Okay. In case of women, we have women or we have women. Do you think asterisk would cover that?
No.
No, asterisk will not cover that.
No.
Will not cover that. So what can I do to cover both?
The question mark interrogative sign.
Great. That was the answer I wanted to hear. Thank you. So this will cover both women, EN and so EN and AN, sorry. And then I can write it here. So it's always a good practice to have each term separately in the history so that we can see that how many items were found for each. Okay, next, what I'm combining with an or. What are the other concepts here? What could be the other concepts?
Female.
Female.
Female, okay. Any idea how we can, any idea of truncations in female?
I mean, there is no alternative of female, I guess. Female.
Or females?
Females, yes, possible. Yep.
Asterisk.
Yes.
So asterisk, okay.
Thank you. So I'm adding an asterisk here.
Okay.
Any other word?
Lady.
Lady, yeah.
Yeah. Or ladies, but here, oh, okay, that's a very good point. Do you think it will be a good idea to do this?
Ladies,
Yes, yes,
ladies.
yes.
But
This is not word usually used in in
yeah,
academia.
it isn't, but it's really good for practice, Joel. So okay,
Yeah.
do you think lady or ladies for to cover both lady and ladies is asterisk a good idea after LAD?
No, I guess ladies go with IES, right? And lady, DY. So
Mhm.
you cannot trunk it.
We can truncate, but the problem in this case is this LAD can lead to a lot of random words, a lot
Oh
of
yeah.
random.
Oh yeah.
For example, ladder,
Yeah.
ladder. So we'll have so many studies that are not that
Like,
would not be relevant.
Yeah. It will create chaos.
Yes, it will create chaos. So I think if we want to add this term, we will add separately lady and ladies.
Mhm.
Also, what were some of the other terms that we that's related to the kind of population that we are targeting? What kind of women? There were some terms that I showed.
Oh yeah, like menopausal, postmenopausal, and
Yeah.
young, older, you know. I don't know,
Yeah.
do you like to specify by,
sorry.
race, ethnicity, or any other social categories? I don't know.
I think no need to go that advanced, Rajia, as there are a lot of problems with that because like younger, older, some other concept. The problem is the risk is that when you are going too further, down the track, then you are more likely to missing article. So the advice is that sometimes we use advanced search if you are good enough. Otherwise, try to be more open, not too conservative. So maybe you need couple of extra days to screen the title, which is fine. But if you miss article with too narrowing down the search, then it's really problematic, right?
Right. Thank you so much, Rakib. And again, I'll share one tool that actually helps looking at the sensitivity specificity of this different search strategies. I found that one extremely helpful for my studies. All right. So menopausal. What do you think should be the right truncation to be used here?
Menopausal, menopause, so menopause should be the end. Yeah.
I think menopause, so that it could cover.
Menopause. Yeah.
It could cover menopause and menopausal.
Right. You're right. Perfect.
Right. So I'm not going into all the details of because there are postmenopausal, premenopausal, perimenopausal.
Yeah.
There's so many variations. So it's just to kind of show you that how it works. So let's now move towards the second concept, which is testosterone therapy. So any guesses? What should I write? Testosterone. Testosterone. I think, yeah, this would work. Testosterone or testosterone. Is there any other way that it's used, Rakib?
And testosterone is fine.
Testosterones as well, is it used?
And it's NS. So it should be N truncation.
N truncation. Okay. Okay. So this is something that we get to know after looking at the literature, that what are the different variations that have been used. So in testosterone therapy, I'm sure there must be other other names as well. So
Trade names, especially trade names.
sorry? Yeah.
Trade names.
Yes, so these are the
Yes.
names that we have to find out when we are scoping the what's in the literature, and then these are some of the terms that we definitely need to add here. So Rakib,
Just to use
can you just-
androgen. It's a
Sorry?
overall sex hormone, androgen. Then you
Androgen.
wrap up.
Ah.
Yeah.
Okay, and these were really the terms that we also found out when we were looking at this one. So this sometimes is very helpful.
Yeah.
Androgen. So yes. Okay. So for now, I'm just for the practice. Okay, wait, we
Okay.
missed mesh terms here. So we can always change mesh terms. So if we have to see if there is a mesh term related to testosterone, we can mesh. Search. So it's always good to mesh your search, mesh up your search. So here you will see what are the concepts that have been included in the mesh term testosterone. So it's testosterone, and then there are so many other things. So these are the concepts that we should also, these are the names that we should also add as keywords. So as a concept, it will be covered, but what if the person who is, so this is actually more manual work. So what if the person missed to add that term into the mesh entry? So we might miss those studies. So it's always helpful, useful to use both keywords and the mesh term, even if the mesh term includes all the concepts. So, okay. Oh no, where's my history? I did not log in. Sorry. So once you have it, okay, I'll just quickly now write and show you. We added women.
I think for the sake of the time, you don't need to be that much thorough. Just give us.
No, I'm just, this is the last step.
Okay.
So it's just like I'm showing how to combine with an or and with an R.
I see.
Okay, I think this would suffice. So women, we will combine with an or with female. Search. Oh, sorry, I wanted to add it to the history. The problem is when you're not logged in, it sometimes you lose the data.
Yeah.
Okay, I have it. Great. And then this I will combine with an and with testosterone. And then I can search. So this will be the two major concepts that I'll cover. But again,
Okay.
this is very, very broad. So we need to have a lot of keywords here and a lot of keywords there. We have 61,000 studies. So definitely there are a lot more filters that we need to add, and
Because you didn't use outcome.
I did not use the outcome.
Yeah, that's why it's all.
That's
and
why
it's,
it's so huge. Yeah.
It's all endogenous and
Yeah.
exogenous hormone has been included here, both the drug as well as body hormone. So everything has been added here. So no.
How many did you end up screening?
I can't remember exactly. Maybe 20 or something like that. Yeah, something like that.
The PMC includes a lot of wait. If we use PubMed, exactly
No,
PubMed, it will definitely reduce, I think.
Rajia, can I ask you a question?
Yeah, sure.
Let's say we are focusing on cardiovascular outcomes. I don't know if it is a common outcome for this kind of therapy or mortality, let's say. I don't know, or as Dr. Raghib said, sexual functionality, whatever. So just pick a key outcome, and that should be. And
in this case, actually, we have a lot of outcomes already. So I wouldn't say outcome is very good, a very good proxy, but since we only are including randomized control trials, this is the filter that we need to add here, study design. Because outcomes, we are very broad with this outcome criteria. So I wouldn't say to restrict it by outcome, but we need to have another filter for randomized control trial. So there are actually a few already made filters that are available, and I'll search and share that with you. So you can always write and then those randomized control trial filters. And so you will have restricted studies that are only RCTs. So that would, in this case, that would really help reducing the number of studies.
Yeah. Excuse me, I have a question that if, for example, during the literature search and we are just working on this meshwork and everything, if we miss truncations of some of the words, so will it affect our findings? Or yes, it will definitely, it may affect the findings, but for acceptance of the paper, for example, if I have missed truncations of certain words, so what will happen at worst?
You might miss the studies, and if the peer reviewer identifies that you have missed the studies, then it's very difficult to be published in a very good paper. So you need to be very, very careful when you build your search strategy, and that is why it involves a lot of scoping activity before that, so that you don't miss any truncation. So even if you're writing, for example, if you miss a truncation regarding regarding, let's call it women or women, you can write, you can have another term as AN and EN, but it's important to cover all the variations.
Because
so
I've seen many.
It's efficient to use truncations, but the main part is not to miss the main keyword.
I've seen many papers in which there are in which truncations are not used in the research strategy, but they are just like low impact journals in which their strategy is not to use the truncation. They are just using the meshwork.
No, I wouldn't recommend to do that. No, it's very, very important to use keywords, because mesh can miss a lot of studies, and this will come further in the presentation. So so if I would be the peer reviewer, I would reject this study.
Don't reject. Don't reject.
But well, that study was published, so we have already covered all of this. So I am just quickly moving it forward. If there's anything,
does it also have to do with that PubMed gives you a lot many results compared to
Medline, Ovid, which is a more specified database. So would that also affect perhaps the quality of the study that we are conducting, or how easy it would be for us to perform the search strategy?
So it's good to have more studies rather than to miss studies in systematic reviews. PubMed generally give more results, but then of course, if it gives more results, there are more false positives. And so it is recommended to use Ovid. If you don't have access, you do not have an option. I mean, if you don't have an access, or if you do not have the collaborator who has the access, then you have no option but screening more studies. But one of the main things is that even with PubMed, you have to complement it with other search engines, including Embase.
Yeah, because we cannot rely on PubMed entirely, right?
That I said here, that is depending on your topic. If it's randomized control trial, then obviously your first preference should be central, and then supported.
Because it depends on the question and the type of study we are conducting. For some particular topics, we prefer one database over others. Also, we have to change our search strategy according to databases, right? Because there are certain words that are in headings in PubMed, but not in Medline. Okay, so we cannot use one standardized. We have to change it only.
Yeah, you got some experience. That's why you can now raise that question. But it's really hard to explain is databases here. But for example, it's Ovid actually is the same platform used for Medline, Embase, PsycInfo, and another one, I think Metana and Infant. So that could be used in the same Ovid platform using the same search terms, and just you develop your search strategy, and then just changing from just in the top, you changing from Medline to Embase and click one, then you got everything. And then from Embase to PsycInfo, then you got, it's just few click and you finish 4 databases. But Phenol, Scopus, Web of Science, and Central, a little bit changed, but it's pretty much same approach.
I'll share a good hack with you in there.
Hello.
Yeah.
I have a quick question. Is it
is it necessary to search all of the databases if I would like to do any?
I think I explained that you no need to search all the databases, but you need to search like 4 or 5 databases to supplement and complement, not missing important citations.
Okay. Then in the method part, just like other research, we would explicitly explain that how many databases we had covered.
No, there is no specific rules.
Okay. Thank you, sir.
Thank you. Okay, so these are the few things that I've already talked about. That mesh search, mesh is really good, but then there are a few cautions that you need to have in mind. It does not work for new or not clearly defined topic. So there are concepts in mesh terms, but if the topic is not well defined, then mesh would not cover it, and does not work for new because it takes some time to index it. The mesh term, since I already mentioned the manual process, so it takes some time. So you always need to complement with keyword search, otherwise you might miss recent studies that were not indexed. So errors or bad judgment of indexers, this can happen. It's manual, so again, this can happen. Misclassification is possible. Authors' keywords are not used, so again, keywords are very important. Only available 3 to 6 months after publication. This is the timeline, so you might miss the papers that have been published in the past 3-6 months if you're only using mesh words. And then there are adjustments that happens with time, so it's always good to complement with keyword search.
And as Razia said regarding the what is called preprint or e-publication, what is called EPUB. I mean, publication before, ahead of print or something like that. So in Medline or Ovid platform, there is an option to change, and you have to do that to select, so that you will be able to retrieve all publication which is in production and accepted. That's another thing.
Yeah, thanks a lot for sharing that, because it's one very important aspect that you need to cover all those literature. So EPUB is a good
Did you?
source.
I think it's in relation to keyword search. There is a mp.mp after keyword, so it is multiple places. That is really very comprehensive. Any keyword appear any places in the article, like including title to conclusion. Any areas, if testosterone is appeared, that will be picked up. So mp.mp.
Yes. It's an Ovid.
Yeah.
Multiple places. Yes, you're right. So whichever database you use, I would highly recommend to see its guide first. It's very, very helpful.
Exactly. Rajia, you go through just basic things, and because you cannot, every database is very detailed and very in depth, and there is a guideline. So, and as I said before, that you are not going to do everything. You work as a team in systematic review and meta-analysis. And I find you got some other responsibilities in your life, like family or education or job. So you cannot be expert in every areas. So don't try to be a very expert in searching database. Then what about the analysis? When you are going to learn that? So if you try to be expert in everything, then your whole life will be on evidence-based clinical medicine. Still you can't do anything. For example, I feel I know nothing, because it's huge. There are a lot of things Rajia explained that I don't know, but I know little. So please just try to understand the whole process, not a specific process. Okay.
We can offer a detailed course later on everything. Even then, we can never cover everything. Never ever. So.
Yeah, we will ask for feedback, and our plan is like, if these people appreciate and they give feedback, we are going to design a complete course on systematic.
Yes, we will be glad to have a course, comprehensive course spread on weekends.
Yeah.
And then,
sure.
as Razia said, it can never be enough, right? Like you can keep on taking courses. I have been taking courses since years, but I'm not stopping.
This is your third course, right?
Yeah, this is my third course. I have worked in this for 2 years, and even during my master's, I was constantly involved in systematic review. But I still think that, okay, I didn't know this. Now I'm learning it from here. So it's just like a work in progress. You cannot ever stop anywhere.
It's true. We both did like 6-month semester course, but still like we are doing so. Yeah.
We can all together do a complete research together, so then we can easily learn each and everything.
Yeah. Razia, what else we have? Otherwise, we need to move to the meta-analysis part.
Yeah. Sorry. I'll
go.
Just this is the last concept. So if we have very few studies, so what we can do is we can increase our concept. So if we were only concerned with coronavirus and attitudes to vaccination, and we found there are just 5 studies, so we can broaden our concept. We can also add other infectious disease and what are the attitudes to vaccination if we are interested in that. So this is one way of increasing the studies, and and this is another way that if we do not want to tweak the tweak the exposure, we can tweak the outcome, we can add perceptions of public health measures general. So this is the summary that we use PICO to come up with an answerable question, and then we decide that what type of literature we need to go through to adequately answer our questions, and then we decide which database is most practical, and then we pick out the key terms, we break the topic into individual concepts, we define words, phrases, we search for each concept as a separate set, and the Boolean operators of we combine it with and, or, and not, which are called Boolean operators if I missed this term. And then we display and evaluate the results, and we refine our search strategy as necessary by combining terms. Joel, I just want to show this very resourceful.
No, you don't have any time.
It's the last thing, and it would really help. So in my recent study,
okay, please show. Don't talk. Please show.
In my recent study, I do consultancies, and what I found out was that so this search refiner. So they gave me a search strategy, and so what I did was I tried this search strategy that how many relevant studies is it identifying. So what happens here is that you find some relevant studies. You have to find that before. So you find some relevant studies, you enter their IDs here, and you enter the search strategy. It will tell you how many studies, relevant studies did that search strategy identified. So that's a very good strategy of tweaking your search terms. It's a very quick demo that I'll show. Yeah.
Is it available for others, or if they don't pay, like, is it free?
Yes, it's free. That's the best part.
Okay, share the link, then we'll grab this opportunity freely. Anything, we are there.
I will share this. I actually just remembered it during the session to share this one.
Yeah,
my clients were very impressed with this, by the way. So
we are also impressed, but finish it quickly.
So these were the PMIDs that I identified as relevant papers. So I am entering them here. And this was a strategy that they gave to me. And then I can visualize. Sorry, it's taking some time. But then after, so there were 20 relevant citations that I asked them to find through this strategy, but they could find only 14 relevant citations. So it was not a good strategy. So I tweaked the strategy then. And I pasted it here. Visualize. So Joel, do you want me to go through Covidence, or it's okay to leave that? I can give a very quick overview.
I think you should go through Covidence. It's very important because I mean,
please go through.
Very few people will have opportunity to go through the Covidence. It's because it's paid. But Rajia and I got the opportunity to work with Covidence team, and I'm working here with the people who develop that Covidence. So you just go very quickly just to give a kind of idea.
Yeah, I don't have any problem if participants are staying longer than the usual time. I don't have any problem.
I think it will exceed 1 hour because it's already.
But very quick, just show very quick.
Yeah. So yeah, here I found that through this tweaking, I found 19 out of 20 studies. So my next step would be I'll try to find which of the study did it miss, and then I will add more key terms in order to refine the search strategy. So it's called Search Refiner and super helpful. Now I will go to Covidence and
Razia, can you please share the link?
yes, I'll share.
Yeah, the previous one.
Want it now?
Yeah, people are asking now.
Right, added that in the chat. Now, Covidence time. So there are many software available for review management, but Covidence is the Cochrane recommended one. So especially if you're performing a systematic review of interventional studies, Covidence is very intuitive in that, and it really streamlines the whole process. It's okay, I can just use this university's access. My personal account, not my Covidence account. So I'll then delete this review. So you can all sign up for free, but when you sign up for free, all features are not available. You can only import 500 studies, and there are some limited features like bulk PDF upload. You cannot use that. But it's really good to know if this is something that is helping in your review. So I would highly recommend everyone to sign up and see how it works. And does it work for a review or not? There's also this, I'm not switching it now, it will take some time, but you can always switch to demo. And I can do that actually. I'll create the new review. So it switched, the demo already has a data set, and you can try playing around and to see that how it works. So it's super helpful if you do not have a data set. So, but if you want to create a review, you can start a new review. I'm not creating a Cochrane review. So if it's a Cochrane review, it links it with your Cochrane ID. So for now, this is out of the scope. So I'm just creating this review, name of the review.
I think it's rather than creating, can I share my screen to give quickly overview?
That can be done, or I mean, I can actually switch to demo and simply show what are the available features that can be used, and how basically the whole process goes about. And it's actually very easy to use. I have used other software. So Distiller is another paid software in consultancy.
তুমি এখন না পাঠাইতে পারলো সন্ধ্যার পরে পাঠাবো এদিকে খাওয়া দাওয়া শেষ অসুবিধা নাই
Can you what I don't know who the person is, but please mute your
I'm no problem.
Okay, thank you. So demo version takes some time to load. Here it is. So this is the dashboard. And so there are these steps. You can always go to settings, and so I'll start with the settings, because as we talked about that there are multiple reviewers who can collaborate. So you can add a reviewer, you can invite a reviewer, you can remove a reviewer. So this was what I was showing, but it has already been set up. So you can decide whether you want 2 people to screen or 1 person to screen. In by default it's 2, because it's recommended for to have 2 people to screen for every step. But we have just kept it as an option in case if the review team does not have enough resources to have 2 reviewers for each step. So you can change for all the steps. So, and this reviewer tab is for the collaboration. So if I am conducting a review and I want to invite my reviewers, I can do that from here. So this is the CEO of Covidence. Who came up with the living evidence concept, and I think Rakib has worked.
He is extraordinary. He is the lead of evidence-based task force. So if you're done, I can show you also quickly with the work that we did with the whole team.
Actually, yeah. Do you have this work? The testosterone. Okay. I think that's better. You can just open up that one.
Not testosterone, but the evidence and some other. Just quickly showing the template. So just giving just because each chapter or each thing is really so detailed. You can't do that, afford that. But I can show very quickly that one. Very quickly if you
okay, so maybe you can use that one. You can use your data and maybe quickly just go through all the steps that happens in that you can do in Covidence. I have stopped the screen share. You can go ahead, share yours.
Yeah, you can see this is the formal login in Covidence, and Julian Elliott, the creator of this fantastic platform. And you can start any review, and already Razia showed how to do that. And you can see there are some review process here. So at the bottom, this is my own honors students project. And this is actually the especially the Australian National COVID Task Force that I shared with you. So every day we are really working on that. So, and then another, you can see that has been published and shared in the previous slide, that effects of forced migration on children's health. So if I just click the bottom one, then you can see that we got finally 85 articles. But if we go before that, you can see how many articles have been really imported. You can see the import option and then title and screening. So that has been set up by 2 people or 3 people, as Razia said, based on your criteria. So, and then full text review. So these are the process, and then you got 85 final articles. And if you want to do extraction of data, you can go there. And as already you can see, this is settings here on top of that. So if you click here, then you can see you can change what should be the number of people involved in the each process, and you can see other options, and you can see who are the people involved here, and these are the our team member, like these are student, these are student, these are student, and this is my boss, and this is myself. And team settings. So you can see who actually did the major work and then who intervened, and there are different processes, right? So if we now go back to the main page, I think I want to show something here as well. You can see who are there. Reviewers, review, yeah. Probably Rajya, you will know Beta Tendon, who is the lead here in evidence-based guideline. And Steve McDonald is the co-director of Cochrane Australia, and Heath White is amazing person who is really doing the main analysis in Magic app, which is very advanced level. And Joshua Vogel, another is a clinical person who is really highly expert people with prenatal and neonatal health and pregnancy health, and he worked in World Health Organization evidence-based synthesis. And all people are really evidence-based expert. So these are the team, every people are working at the beginning. So this is COVID. There are a lot of options here, and we have seen at the beginning in our first endometriosis analysis and systematic reviews that there is also option for extraction. So, and then you can go for Prisma. So I think there are a lot of things we can't afford here in detail, but this is the most comprehensive formal platform for managing your citation and data extraction. Is there anything to add, Razia, or is that okay? I think you are mute. Mute. You are muted.
I was thinking to maybe quickly go through all the stages, like you import from here, and then how you screen, and then how you set up the exclusion criteria for full text, and then how you go to the data extraction. So really all the steps.
I think it will take ages then.
No. It
okay,
just like,
I don't want to go that process now, but if you want, it's fine.
I can just very quickly show all the stages, because we have talked a lot about it. It's just better to see how it happens. So this is one of the studies that I did, and Joel, I'll just take 5 minutes. Okay, so you can import from here, and then when you import, there are many duplicates that are removed. It removes itself the duplicates. So for import, you can always click here, and then it automatically removes the duplicates. If we can check the duplicates if we think that we want to include, we want to override duplicates, like we are saying that if it's not a duplicate, we can also mark that. And if we want to manually mark duplicate, we can also do that and then see that from here. So here I can mark not a duplicate, not doing that, sorry. Yes, Umardad, you can ask your question.
Yeah, can you please show us how to import, and could you please also tell us like where does it import the articles from? Is it like one database, or you have to, maybe I've joined late, so perhaps that was discussed already.
That was not discussed due to the time, but I actually wanted to discuss that because it is pretty much important. Okay, maybe I'll just go through this, and then later I can show you how really to import. You can import in different stages. You can import to screening, or you can import to directly full text review, or to extraction. You have this kind of an option. I'll just show how it looks like, but I will not import at this point. So yeah, sorry. And the other question that you asked, can you import from different databases? Yes, you can import as many times as you want. You can import unlimited studies. You can import studies in millions. But the problem is that you can only import 20,000 at a time. Sorry, 5,000 at a time. I forgot this exact number, but it shouldn't be, your file should not be more than 50 MB. So if it's more than 50 MB, you will have to divide it into batches and import them in batches. So you can import unlimited, but in one single import, there is a limit of 50 MB. So you can import to any stage of the review, and then you can just click here. So it will be imported. And you can see the import history from here. If you have imported from multiple databases, you can just see the history. So in title and abstract screening, actually I've done this review, so it might not be very intuitive, but you have 3 options of include. I think demo version was better. So in the title and abstract screening, so we have these options. We can screen the references, and then so if I'm screening from my side, Rakib is screening from his side, and if there's a conflict, so if I say yes, Rakib says no, so it will be included in the conflict. And so either one of us can resolve the conflict, or we can say Joel is the judge, he will decide. So we can set that in the settings, that Joel is going to decide who's going, that should it be included or not. So this team settings help with that. So these are the references that I can screen. I can write yes, maybe, or no. Maybe is treated as yes. So demo version, that's fine. So generally in normal versions, it does not happen. It would just direct. Okay, right. So it's very easy. You can just see the paper, and for some reason, this paper was imported without an abstract. So I will say maybe, because I'm not sure if I have, if this is that, maybe if I read the abstract, I might know better. So in such cases, we generally mark maybe. So we then see it in the full text stage. So this is how the whole process is done. You can add the keyword highlights from settings, and then it will highlight the words. For example, if I want that women should be included, so I can highlight the word women or female or testosterone. So it will just highlight those words, and I can then decide based on that. I shouldn't have clicked that, but and here you can also write inclusion, exclusion criteria. You can open it while you're performing the screening. So,
and do you just I have a quick question. Usually as a researcher, when do you go for the full text review and when just only the abstract review?
We always start with title and abstract before going to full text, because if we start with full text, we end up doing it in I don't know how many decades. So full text screening takes a lot longer than title and abstract screening. So you can simply screen the titles, because in a lot of cases you will just see from the title, you won't even have to go to the abstract to decide whether or not it's relevant. So so it's just very important to start.
Okay, so I think what I understand is the relevancy is based on the intuition or insights of the reviewers.
Inclusion and exclusion criteria, the one that is set at the protocol stage.
Exactly. Okay, understand. Okay.
And we can always write this in distiller and in Covidence, and we can see what was the criteria that we set. And so so we have it there, and by looking at the criteria, we are marking yes, no, or maybe. So those that have entered that we included here then enter to the full text screening stage, and then you can screen from in this stage. And for this stage, when you exclude, you need to tell what is the reason you're excluding. So because in Prisma, you might have seen that we have to write how many studies were excluded on which basis. So this is why it's so comprehensive. This reporting is very important. So when you're excluding, you need to decide. So for example, if I say it's a wrong setting, I'll confirm this, and this will be added to the wrong setting. If the other person, my second reviewer, also select this as an exclusion criteria, then it will be marked as wrong setting in the Prisma diagram that Rakib already showed. If Rakib marks exclusion on any other criteria, it will go into conflict, and that needs to be resolved. So if I include it, then I don't need to write any reason, because it means that it has met the eligibility criteria. But for each exclusion, I need to specify the reason. And then the next step is data extraction. For data extraction, sometimes people use Covidence, sometimes a lot of people are used to using other forms or Excel. So it really depends on the preference of the review team and how techy they are, because it takes some time to set up the template. But once you have set up the template, it becomes very easy to extract the data. You have in one place, you have you can see the study, in other place you have the options to extract the data, and if you do it in the software, it's more standardized than doing it in any other sheet. So this is data extraction, and there is this form which is a default form. So when I say default form, so you can start from the scratch, or you can modify this form. But some of the information is very standard that we generally use in all studies, like the general information, what's the study ID, title, who's the author, country, characteristics of included studies. So characteristics of included studies is very important, because this is something that needs to be reported in the manuscript as well. So participants, so what's the participant description? What's the inclusion criteria of participants? So we are saying women above 18 years of age, if that was the inclusion criteria. So we need to here specify what was the age. So and then what was the study design included, start date of the study, end date of the study. So here you can always change, customize this form according to whatever is feasible, whatever is the requirement. So in the participants, I can form any table, and I can write any heading. So for example, male, female, and then here in this case, it's only female, but it's just an example. In the row heading, what was the number, or what was the percentage? Do you see that happening here? Yes. This is how it will show. So once we're done customizing the whole form, then we can either save it as draft, or we can publish. Once we publish, we can then use this data, use this template to extract the data. So this is the last thing that I want to show. There is one issue. So I have not imported the full text, so I won't be able to show that how exactly it looks like. It is at one in the left hand, you will see the study, in the right hand you will see the form. So has there anyone who has already used data extract Covidence?
I don't think so. Anybody use Covidence as of today, except you and myself. Maybe a couple of, but I don't think so.
Okay. So
if people are not working under the Cochrane group, then it's really less likely to use Covidence.
Oh, by the way, I need to tell you all this, that very less people know that for LMICs, Covidence is free. I forgot to tell you that. So for your next review, you can use Covidence for free.
Oh, I didn't know that.
Yeah. You cannot use it because you're based in Australia. So, but for those based in...
Is it full access we have?
Sorry?
Are you sure we have full access? We can do
Yes,
all.
I provide the access. You can email me.
Yeah, please do, because I tried earlier, it was, they were asking payment.
That's
But you were
fantastic.
based in Canada.
No, I tried like when I was in Bangladesh, whatever.
I
We
think
For
it's
like,
great.
anything,
I think it's great to know because people don't have access to EndNote as well. So if there
yeah,
is no opportunity for Covidence, so I prefer EndNote is the second best. But if there is free, so it's fantastic.
yes. And you can always, I'm just adding this email address. So if you want the access, you need to email here, support@covidence.org, and you will instantly get the access. So,
Thank you.
that's
So we can assume that Covidence is free from Bangladesh.
yes.
Okay, thank you so much.
So
Okay.
there is this list of LMICs, which includes Bangladesh, which includes Pakistan, which includes Africa, a lot of South African, East African countries. So according to World Bank, whichever are the countries included in lower and middle income countries, Covidence is free. But not for all the reviews, for I think a couple of reviews. So you
yeah,
can
that's
start.
what you need to mention. Okay, so because we cannot do like the whole review, maybe.
No, you can use it. You can use it for whole review, but you cannot use it like for 3 or 4 reviews.
Yeah,
you-
just specific number of reviews,
Yes, a specific
not
number.
unlimited, and you keep doing it.
Okay,
Yeah,
so for
not for
as far as-
lifetime.
okay, for example, if
Okay,
I have
Razia,
my
I think like we're done with our respected time. So now we are more than 1 hour behind. So now,
Well, really wants me to shut up, so I will just
yeah, I really want you to shut up, and I want to give this floor to Dr. Rakib Islam.
Right. Okay, I'm just wrapping up. So in the right side, you will, when you upload the full text, you will see the full text, or in the left side. And then on the right side, you can just see the full text and you can extract the information. And it's very easy when you have the template there, you can just click. Otherwise in Excel, you have to write a lot of things. So do use that. So it takes some time to form the template, but once it's done, it will be very efficient for the data extraction overall process. There's also quality assessment template. I'm not going towards that, otherwise Joel's really gonna kill me. But you can, so quality assessment template, you can again set it up from here, and once you have set it up, it will blue from blue it will turn to white, and that is the time you can use it here. So here from extraction, you will also see quality assessment after. There will be 2 options, data extraction and quality assessment. So when you click begin extraction, so you can do both. Okay, I'm done.
Okay, Razia.
You can also export the data. Last point, sorry.
No,
Because
I'm saying if there is an opportunity to involve me in this kind of from very beginning to ending process of data extraction in your Covidence team, I would be very happy to be involved.
Great, I'll let you know. Actually, we are working a lot on the data extraction, because so I've used some other software like Distiller, and there are a few very good features in there that I'm trying to integrate in Covidence as well. So this is a process that we are doing, and hopefully by the end of this quarter, we'll have even better data extraction template.
Okay, great.
So,
Wow.
and yes, I'll let you know for any data extraction project. And from here, you can export the data. You can export it in CSV, and so you have it in Excel, and that is the data that you can further use for analysis. And analysis is something that Rakib will share. In export, you can export all kind of data. You can export the references that you have screened, or references in any stage of the review, and these are the formats from the that you can use to export. And this is the for data extraction form. You can download all kind of forms. So if I and Rakib are doing the review, so I can download forms for myself, for Rakib. And if I don't want the form for individual, but I only want the form that are based on the consensus data, so I can only download this one, because this is the one that is used for analysis. And these are the quality assessment data that you can also download. Okay, I am done. Thank you so much. And you can always ask any question about Covidence from me, and also the link, the email that I've provided. We are very fast in answering any kind of technical question. So, all right, over to you, Rakib.
Great, very
one thing. Yeah. Sorry, Rakib, go ahead.
No, I think people need break. I'm really suffering from hunger.
Yeah,
Really
that's what. Yeah, I can get it like from your voice. Okay, guys. Two more thing, like maybe I have already shared with you like 4 different templates. So the people who don't have access and who don't want to go for those hassle for data extraction, you have the template, Excel template, you can extract manually. So that's what poor people like me do. Okay, so rich people like Razia, they go for Covidence, they have unlimited access and they use that. And another template I have shared with you, if you want to write the protocol or prepare the protocol for your systematic review and meta-analysis, you can follow that template and you can submit to Prospero for registration, as well as if you are interested for publication, you can use that. And 2 other attachments I have shared here in Zoom, you should also download that. It's one about the quality assessment, that's what Razia was talking, and Dr. Rakib will explain it well later on. And also how can you review the systematic review to assess its quality, whether it's really done in a rigorous way or it meets all the criteria. So you can assess that. That template is also at us and you got it. So everything now, rest of the 2, Dr. Rakib will explain when he'll be talking about analysis. So over to you, Dr. Rakib.
Thank you, Joel. I'm going to share now the 3rd part about meta-analysis.
So one more thing, Bhaya, you can ask like our participants, because it's been a long time. I'm not sure like if everyone is comfortable and how long they want to spend. So you can talk.
Yeah. Is there any comments or how long you can wait? I mean, stay or I mean,
or did you take your lunch or not? Or you can take your lunch and eat like.
Yeah.
Any comments, or you all are still energetic to go ahead for 1 more hour? Guys?
I'm up for it.
Yeah, show some energy with thumbs up, or like you have lots of reaction button in Zoom. Down or up. You can show both.
Okay. Great.
Okay, seems people are energetic still. So I think you can go ahead.
Mm-hmm. Is it full screen?
Yes, it is. It's perfect.
Okay, so I'm going to talk about analysis part now. And before going to do that, I will talk about a little bit the strength of study design, that is the evidence from it. So you can see the question came up early in the morning about the case reports, case series, and ecological studies. So you can see the meta-analysis or systematic review is actually sitting on top of the pyramid. So if you are doing systematic reviews based on case series, then your evidence should be obviously very loyal based on this evidence from the original studies. So if in study design, RCT or randomized control trial is considered as gold standard study design because of different risk of biases that usually eliminated during the study design stage. So when you are doing meta-analysis or systematic reviews based on RCT, then obviously it will provide robust evidence for clinical practice and policy implications. So this is, how can I bring that top layer at the down, because it's
I think it's fine. You can see.
no, it's there is some level really hindering my text. I don't know how to do it. Anyway, I can't fix it. So cautionary tales. Sorry. One should not conduct a systematic reviews and or meta-analysis or meta-synthesis. So probably you know John Ioannidis is the medical professor from Stanford University who has been working last 20 years on evidence-based clinical practice. So he said that an estimated 97% of the systematic review and or meta-analysis are methodologically incomplete, redundant, and provide unhelpful or potentially biased clinical information. So this is important to keep in mind when you are doing systematic reviews. The processes that has been discussed so far is really huge process, and you are not required to be expert for all steps. But you need to keep in mind that the evidence you are going to generate is really accurate. And what are the reasons actually you might be producing inaccurate and very dangerous evidence for clinical practice? The first thing is that duplicate. So there might be existing review, so you no need to do that review again. Or there is a review, but you need to update, or may not be needed any update, because if there is something, as I said, for example, in my case, maybe in next 5 or 10 years, there is no need to be updated this review, because there will be potentially very, very few or no randomized control trials in this field. Second problem is the lack of methodological or content expertise in the review team. This is very, very common nowadays, because I'm one of the editorial journal editorial board member, and I'm pretty much responsible to look at most of the systematic review and meta-analysis submitted in that journal. And I found most of the review that I go through, I had to reject, because there is a huge methodological flaws in that review. And they do not really consult with the expert people when they are conducting systematic review. So you no need to publish just for publication, just for increasing your number. If you really, really want to be a evidence-based practitioner in your career. Another thing is that database has not been searched comprehensively. That's happened due to the restriction or unpaid database access to low and middle income countries. So what people do, they use PubMed and Google Scholar, and then they try to develop systematic reviews. Rajia and Joel, can you please look at the chat box and answer if possible, or please let me know whether I need to.
Yeah, sure. I'm following you. No worries. You can go ahead.
The next,
Yeah, I'm following the chat box as well. So go
okay,
on.
thank you very much. And the fourth reason that you need to be very careful is analysis is not appropriate or not needed. As I said, there are a lot of problems with the meta-analysis, that people do meta-analysis when meta-analysis actually distort the evidence. It is not necessary that you have to do always meta-analysis. As I said, our one aggregated data review, which is published in the BMJ, and then based on that evidence, we go for individual level data, and that has been published in the Lancet Diabetes and Endocrinology journal. Both are highly impact and top one journal in a specific field, but there is no meta-analysis. So you need to be very careful. Results and interpretation did not account for both statistical and clinical heterogeneity, or you can say risk of biases. When we are really talk about that, when we are talking about this evidence pyramid, actually this pyramid is based on the risk of bias. If you are really sitting bottom of the pyramid, then there is a huge amount of different sources of bias that you cannot really mitigate. But when you are going top like our city, then you are more likely to reduce most of the biases. So that's the thing here. When you are doing systematic reviews, you must account for different kind of selection bias, reporting bias, measurement bias, a lot of different kind of bias that we'll little bit discuss later. And also risk of bias biases have not been considered when interpreting the results. Whatever the results you get is fine, but you have to interpret the results that these results should be interpreted with caution. This statement is very important. Sometimes most of the people try to avoid that risk of bias, and most of the people intuitively want to provide positive things always. They feel that this is their credit, but not. Even negative is fine, but you need to be very honest, and you need to interpret the results with risk of bias. Any questions so far? No. I don't know. Can I stop sharing and try again, because I can't see some text because of these Zoom issues. Okay, that's better. So now we'll talk about a little bit analytic methods for qualitative and quantitative systematic reviews. So sometimes, people use qualitative systematic reviews and quantitative interchangeably, especially the meta-synthesis and meta-analysis. But you can see they're completely different, and meta-synthesis actually on its own rise is a very specific tool to analyze your data. And meta-synthesis is the systematic review and integration of findings from qualitative studies. And sometimes you can do your mixed method systematic review and meta-analysis. So some part could be, data analysis or data synthesis, and some other part could be meta synthesis. And meta-analysis is the investigating the data from a number of independent studies of the same topic in order to determine an overall evidence that we have discussed at the very beginning.
Sir, I have a question.
Yes.
Can I ask? Okay, sir. Sir, my question is, if we have got a few number of studies, for example, 100 studies or 50 or 60 studies or 20 to 30 studies in any topic, because I am a physiotherapist and in my area, when if I narrow down any topic, then the number of the studies become very limited. So in such cases, is it feasible to conduct any of the systematic reviews or meta-analysis, if I say?
I think we didn't say any time point that the number of articles should be this or that. What I discussed so far, that if you want to do a systematic reviews, then you need some criteria and you need to follow that processes or steps in doing systematic reviews. But if you
Exactly.
get, I have seen, if you get more than one paper, then you can do systematic review and meta-analysis. I have seen one Cochrane reviews that has been discussed in a big forum in Cochrane group that only included 2 studies to do a systematic review and meta-analysis by the Cochrane group. So, because there are no other papers, randomized control trials on that particular very specific topic.
Okay, thank you, sir. So in such cases, if we do not have enough RCTs, then we can go for the non-interventional studies.
This is great question, but I think the randomized and non-randomized, it is always advised not to combine both in one review. So it's better to split and report separately, because the evidence is quite different when you look at the pyramid. So it is not possible to combine, and sometimes it's very difficult to interpret the results when the evidence is quite different from observational studies compared to randomized control trial.
Thank you, sir. Thank you, sir. I was wondering this question. Thank you, sir. Thank you so much.
Then that has been talked about, I think, the application of statistical software in meta-analysis. There are different statistical software or meta-analysis software out there, but Stata is really commonly used, and Cochrane using RebMan. And as I said before, that whatever the software you are using, please use the updated version to get the most out of it. And I use RebMan when I did my big systematic reviews, but the problem is that there are some numbering system which is inbuilt in the RebMan, and I cannot change it. But when Lancet asked to delete that and provide a kind of customized graphs and figures, which is really, really difficult to do at that time in RebMan in 2019. I don't know that that has been updated now. Then I had to reanalyze all my data in Stata. And in Stata, there is a huge opportunity that you can customize and you can change whatever you want from your graph or from your figures. So it's really, really very easy to meet any criteria by the journal. So that's why probably Stata is most commonly used. Another thing is that our software is also very good, but there are many people or researchers or students really struggle with our software because it's a little bit advanced compared to Stata, whereas Stata is very commonly used in general research and data analysis. That's why it's very easy to use that expertise when you are doing your meta-analysis. Statistical aspect of meta-analysis. So as I said, this is very important to know that so far we have discussed today, we all talk about the conventional systematic review and meta-analysis. That is, we include all published articles, and we use their effect size. It could be prevalence, it could be incidence, or it could be odds ratio, relative risk, hazard ratio, and so on. So we try to use that effect estimate or raw data, and then we combine these effect size in meta-analysis. But there is another way of doing systematic reviews and meta-analysis, which is most common nowadays, with individual patient data. This is gold standard meta-analysis. In this case, you get individual level data from maybe, say for example, we did that for our, the best example is, I think, in our diabetes research that can show, or just a moment, I will, okay, let's carry on, then we can come back again. So one paper that, as I explained, when I did my first postdoctoral, then we actually look at the trends of incidence of type 2 diabetes across the world based on published data. Then we have seen most of the studies, most of the countries actually incidence level is either declining or stabilizing. Only one country so far I can remember on top of my head that is increasing. Then that actually given a kind of intuition that, okay, this is the published data, but there is a lot of problems with the published data. For example, one study published in 2000, another study published in 1990, another published in 2015, another published in Australia, another published in Canada, and some study adjusted some number of variables, while other study actually adjusted different variables, as well as some study included very large age group, while other study only included people those are 40 years and above. So you can see there are different variation within the whole studies. So that variation you cannot actually change, right? Because that studies, single studies are conducted by different people. But what you can do, individual patient data or individual participant data, say for example, if you get 1 million people's diabetes registry data from US, and say 20,000 people's diabetes registry data from Australia and Canada, and from different countries. This is individual data. So you got your individual data now, your analytic approach should be exactly same for all data. If you want to look at the group-wise incidence, then you can do it in your own way. If you want to look at male and female variation, you can easily do that. But in published data, maybe people are reporting male and female together, all people together. So you cannot stratify now these aggregated data. So this is the benefit of doing individual patient data or individual participant data meta-analysis, which is becoming very popular and very robust and gold standard meta-analysis. But so far we are talking about now aggregated data. And then the next question is that analysis choice of models. So what should be your analysis models preference? So that it should be fixed effect meta-analysis, or it should be random effects meta-analysis. So it's depending on what kind of data you have. So in fixed effect data, we assume that all samples come from the same population, then you can do, or the treatment effects are pretty much similar, then you can do fixed effect meta-analysis. But usually,
sorry for interrupting. Excuse me.
Yes.
Can I, at this point, I want to ask a question that who decides that it is a fixed effect model or random effects model? For example, we are researchers and we want to submit our systematic review findings to a statistician for meta-analysis. So will the subject expert of statistics will tell us that whether it is a fixed model or random effects model, or we as a researchers have to assign these models?
Yeah, that is the question. That, as I from the outset, I said that in your team there should be someone who is expert in methodology. So it could be he or she should be expert both in epidemiology as well as statistics. So your data nature will tell you whether fixed effect or random effects model should be used. The problem is that most of the cases it should be random effects model, but if you incorrectly use fixed effect model, then you are more likely going to show the positive effect, which is really problematic. But if you use random effects model, then it's going to be really not significant effect, right? So then the evaluation of heterogeneity. So that is the most important part again. So after doing the fixed effect, or especially the random effects model, then you will see the heterogeneity. I mean, there is a variation of the effect between studies, which is denoted by I-square. I will talk a little bit more later. And you should consider, based on this heterogeneity, you will go further advanced analysis or not, that I am coming later. And then there are also clinical heterogeneity. The problem is that those people are little bit expert on systematic review and meta-analysis. They are only focusing on statistical heterogeneity, but they are not focusing on clinical heterogeneity. But clinical heterogeneity also really impact your variation of estimate. So that should be also need to be addressed when you are interpreting your results. And then there might be some effect by groups. For example, in our case, maybe the effect of testosterone in older women could be quite different when compared to younger women. So you cannot combine whole group together and provide a robust evidence, because that evidence might not be applicable for younger people. So what you need to do before combining that, you need to look at subgroup analysis, so that every group got the pretty much similar, or at least significant impact. Then this is really makes sense to combine, right? Then meta-regression, and we can also look at that statistical heterogeneity or clinical heterogeneity based on meta-regression. So you have done your meta-analysis, and then you want to see what are the factors actually creating this heterogeneity. You can use that meta-regression method. This is a kind of, in general, logistic regression or linear regression kind of things. Is just adjust some other kind of confounding variables in your meta-analysis. So this is pretty simple things, but you need to further explore when there is a huge heterogeneity. And then 95% confidence interval versus 95% prediction interval. So this prediction interval is pretty much new concept compared to 95% confidence interval. So when we are reporting our effect estimate, we really reporting with 95% confidence interval. That means if your BMI is, say for example, obesity in Pakistan is like 25%. This is your sample statistics. When we use 95% confidence interval, then maybe your lower boundary would be 23 and your upper boundary is 28. That means this is the population estimate. That means this is 25% is obese or obesity, but that could go minimum of 23% to maximum of 28% when you are doing 100 research, especially 95% cases or 95 research will get these results. So this 95% confidence interval actually talk about your existing studies that you included your meta-analysis. So as I said that evaluation of heterogeneity. So evaluation of heterogeneity means that heterogeneity start from 0 to 100%. So if 50% or more heterogeneity, then and your result shows that positive impact, then you are required to do 95% prediction interval. So it is showing that with 50% or more heterogeneity, your treatment got a positive impact based on the included studies. But the question is that, okay, this is very effective treatment, but what will happen if we do future randomized control trial? So you can see the 95% confidence interval talks about the existing studies, but 95% prediction interval tells about whether the future studies, if you conduct one, will provide positive impact or not. So some studies, some meta-analysis may provide significant 95% confidence interval. That means significant, positive effect based on 95% confidence interval, but might not provide same significant level with 95% prediction interval. So that means based on your studies, your treatment is positively impacting, but the future study not necessarily will provide positive results. So that is very important information for future research. Another thing is publication bias. This is very common in systematic reviews and meta-analysis, especially when you are doing experimental or randomized control trial meta-analysis. So publication bias is a kind of reporting bias. There are a lot of biases in studies, but publication bias is reporting bias. This is mainly, as we know that most likely the positive results will be published, but negative results are less likely to be published. That means when you are aggregating your studies in your meta-analysis, you are most likely including your positive results only. But what will happen if you include negative results as well? This is problematic, especially in drug research, because most of the randomized control trials are funded by drug companies. So when the results are negative, then drug companies actually seriously influence not to publish that results, because that will seriously, they will be seriously in economic loss. So what's happened then? So you are only including positive results in your systematic review and meta-analysis, and that meta-analysis provide a kind of bias estimate, which is really problematic. We will talk a little bit more about that. So is that any questions so far? I will now go step by step based on our clinical trials that we, review and meta-analysis that we use clinical trials. And so far we discussed from the very beginning. I will slightly go one step by step for this publication, and little bit analysis at the end. So that will clarify more. Is there any question so far here? No? Okay. So now I will go there about my systematic review and meta-analysis. As I said, the first thing should be, review team. If you look at the author, the last author is Professor Susan Davis. As I said, she has been working on testosterone and women's health last 30 years. And as I said, she is involved pretty much all trials across the world. She knows what are the trials are published and what are not. So she has complete understanding about the topic. And you can see the second author, my second boss, who is medically trained professor, and she is very expert in methodology and epidemiology. And the third author is Sally Green, who is the boss of a handbook of systematic review and meta-analysis, which is known as Bible of Systematic Review and Meta-Analysis. She is the co-director of Cochrane, Australia. And the next author is Matthew Page, who is, the recent or update PRISMA guideline has been published, and Razia showed that it's a PRISMA 2020, and he is the lead author of this PRISMA guideline. So, and I am probably the most layman person here. So you can see the review team, how expert they are. So most of the work, kind of field work that I did, supported by Professor Robin Bell and Professor Susan Davis. So there's an enormous amount of work by these three people, but very, very high level comments or suggestion provided by Sally Green and Matthew Page in some point. So you can see how important review team is. Then the objective. So our objective was to systematically review the complete published or unpublished literature of our cities of testosterone for women. You can see our prior hypothesis or objective was to include both published and unpublished literature. So in our case, the result is not big difference, but it could be quite different that we will discuss later. Then to perform a meta-analysis where possible, you can see this is the protocol that we prior said a kind of analysis plan, but still we are not sure. We assume that we can perform meta-analysis where possible, but if not possible, it's fine. And the next step is review protocol register, which is not formal protocol, is for registration only. So we have done that, and then that protocol has been published in Systematic Reviews, which is one of the, I would say, the best evidence-based journal in the world. And they published a lot of protocols, but publishing your protocol or systematic review in this journal is really, really very difficult, even though the impact factor of that journal is around 4. But the editorial board and chief editor, all are big evidence-based people. Like the editor-in-chief is David Moore. I think those are little bit experienced with the evidence-based practice. They know that David Moore is one of the prolific evidence-based practitioners in the world. So it is low impact, but it is very difficult to publish your work in this journal. If you can publish anything here, then any people in the world understand that you know how to do systematic review and meta-analysis. Then our primary outcome was sexual function. So I'm talking here based on the article has been shared with you. So sexual events, I will talk about, especially the analysis should be sexual events or satisfying sexual events. So there are a lot of other domains when we use validated sexual function questionnaire, for example, a sexual desire, satisfaction, orgasm, pain. There are a lot, self-image. So I'm not going to talk about that for right now because it's huge. And there are a lot of other outcomes, as I said, like cardiovascular disease, musculoskeletal health, psychological well-being, depression. So I'm not going to talk about that. And the major thing was the secondary outcome is serious adverse events. As I said, that the previous review actually not that comprehensive. I'm not really looking at the harms of the therapy or treatment. So that is one of the most important things, is that our sexual or your sexual function is improving, but what would be the serious adverse events? Then criteria for a study to be included, that is the inclusion and exclusion criteria that should be based on your clinical practice again. So RCT, as we are trying to look at the efficacy of testosterone, so all should be double-blinded randomized control trial. All participants and assessor have to be blinded to treatment that I said before. And treatment duration of at least 12 weeks, because based on Professor Susan Davis' clinical expertise, she found that if 8 weeks or 4 weeks, then the effect could be due to SANS, or if it's really too long, then it could be diluted. So our treatment duration would be at least 12 weeks to be included in the review. And the comparator, you can see had a placebo. So placebo is denoted by P, and treatment, or an identical comparator. That is, both group has estrogen plus progesterone, plus minus progesterone, and estrogen plus minus progesterone plus testosterone. So this is a little bit critical comparator, but those are medical backgrounds will understand very easily. But this is a kind of 2 arms, 3 arms, 4 arms kind of randomized control trial. But this is different question. If I really want to explain more about the different arms of the randomized control trial, it could be 2, 5. It depends on. And you can see the participants is 18 to 75 years, because this is again, based on her expertise, that why we didn't include 75 years and above, because after postmenopause, whether people are really sexually active after 75 years or not. So that's.
I have a question here, sir.
Yes.
Sir, I'm very sorry to interrupt. Hello, sir. I have a question here.
Yes.
Yes, sir. My question is there any hard and fast rule as to how we would decide the inclusion criteria or exclusion criteria of the systematic review or meta-analysis? Because in other type of empirical studies, as far as I know, the inclusion and exclusion criteria are quite the choice of the researchers. So
yeah, I think I said many times, we said that there is no hard and fast inclusion criteria, because for each topic, and even within the topic, different people might set different inclusion and exclusion criteria to answer the research question. So if this review is done like to look at the safety and efficacy of testosterone in women, in postmenopausal women, then obviously the participant age should be 50 years and above, or 50 years to 75 years, or maybe 40 years to 75 years, because there are very few people in low and middle income countries got natural menopause around 40 and 42. But there are some women might have surgical menopause. So it's depending on if I think that I will look at only the natural menopausal women, then obviously you are going to 40 and like 75. But if you are thinking that I will include both surgical and natural menopausal women, then your age should be 18 and 75 years.
Thank you, sir. Thank you so much.
Well, I was questioned that, for example, if we are doing a meta-analysis of RCT, randomized controlled trial, so do we have to read the literature of the randomized controlled trial first? For example, we have found like 5 randomized controlled trial of which we have to do a meta-analysis. So after reading the randomized controlled trials, then we can make a inclusion criteria, or we can make inclusion criteria before reading the whole literature of RCTs.
That's why I said again and again. I think you guys are looking at very specific point. So at the first slide or second slide, I said the cautionary tale. You need to look at very broad lens. You might feeling that this is very important, but I would say the very important thing, your review team expertise. The question you are asking actually will be obsolete if there is someone expert there. He or she will decide what should be the research question and what is whether there is any potential for meta-analysis or not, even though he or she knows that there must be a meta-analysis option, but there is still the language should be if there is a possibilities. So it's all about your expertise. If you are expert on this field, then you can easily tweak those things in your own way. But it is really hard to look at PubMed or Google Scholar and without having long standing career or experience and just doing 2 days search or 3 days search or 1 week reading, then you feel that I am good enough to decide everything, then it's really problematic. Someone working 30 years or 40 years or 20 years, and I am doing in 1 week, then I am just comparing myself with someone got 30 years of experience. That's why review is not a single person work. This is more about collaboration and teamwork.
Okay, thank you.
And studies published in any language, this is very important. Usually in a very small kind of reviews that we usually do in low and middle income countries, then we very quickly or very easily decide that only English language. But this is really kind of publication bias kind of thing. So maybe not in Bangladesh that you will get good randomized control trial in Bengali language. But if you look at North American countries or European countries, like in France is really good in terms of public health and medical science. So they might conduct any review in French language, and French language is highly regarded across the world, or Spanish language. So you should not exclude any study that published in different languages. So you have to interpret, or you have to find people to explain or interpret that results or translate that results to be involved in your review. So exclusion criteria, studies of intravaginal testosterone, that obviously the expertise.
Can I just interrupt? Please check your message. Just.
Okay.
Yeah, I think just maybe you are not seeing the message, so that's why I asked.
That's and studies published before 1990. So the study time could be 10 years or 20 years. In our case, we use 1990 because our expert person already know that there is no randomized control trial before 1990. And database search, you can see we use Medline, Embase Central, and Web of Science. And this is very important that most of the cases people don't use other sources, this kind of sources. But as I said, the expert member already know about that and involved this kind of organization and trials companies. So that's why you can see we use drug registration application to the European Medicine Agency as well as FDA in US. And this is the source time use already Razia shown. So this is the formal database source that has been used and added by or operator or and operator, and then we find the final articles. And this is the Prisma checklist that has been shown by Razia, but that was a little bit difficult to follow. But this is more, this is not updated one, but it's advised that you should report total number of retrieved articles as well as database specific numbers. And then you go for duplicates and screening, and then you got your final number of.
Sir, I have a question, sir. I have a question here, sir.
Yes.
Okay, sir. Here my question is, for example, if I conduct any search in any topic with any keyword today, and the search result of the same topic and the same keyword after a week, there might have some changes because the total number of article might be changed. For example, 1 or 2 article add or something like that. In that case, how a typical search is done? For example, when you have done
can you please make very clean question? I'm really lost. What is your question? Because you are going back and forth.
Okay, sir. Okay, sir. My question is, if we do a search today and do the same search after a week, if the total number of article is not the same, then how we will write it?
Okay, I understand your question. This is often asked. Maybe this is very good question. I mean, you start with the database source and you start doing that, and before submission or before writing the paper, you have to update the search with current. If your search is older than more than 6 months, then reviewer will ask you to update your database search. So it is advised that when you are completing and writing your review, you at that time you should again update the search and check whether there is any new studies.
Okay, so the ideal norm is, I should regularly search to check if any article adds or if any change.
Yeah, if you can afford time to do regulars every week, that's up to you. And this is the risk of bias. This is usually done in Redman, and it could be done in kind of Excel as well. So this is a risk of bias used for randomized control trial. So there are 7 items: random sequence generation, that is selection bias, allocation concealment, selection bias, blinding of participants and personnel, that is performance bias, blinding of outcome assessment, detection bias, incomplete outcome data attrition bias, selective reporting bias, as well as others. That others actually include that's conflict of interest and source of funding. As I said, that especially in drug trials, if funding is by the drug company, then there is a huge problem of bias. Then statistical analysis, the preferred reporting items, as I said, that we use that one. And sometimes, your effect size is reported in graphs, but you can't get any numerical numbers or data from the graphs. Then you can use Digitize It software, which is very fantastic software that you can use free for 1 month for one computer. If you're using first time one computer, then it will be valid for 1 month. So you can use that and extract data from the graph. Even though there is no data, you can get the numbers. This is really fantastic. And the analysis we use statistical software is Stata. And for meta-analysis, we for randomized control trial, we use METAN command. And for, I think I should update here, and for observational study, for example, if we want to report prevalence, then you should use MetaProp. And publication bias was assessed using funnel plots or statistical tests. Funnel plots is the graphical way of reporting your publication bias, but this is not great. So it is advised that you go for different kind of statistical tests, for example, IGAR test or Bayes test and some other tests. So then the problem with the, as I said, that there is a appropriate statistical analysis. This is comes here. So if you are using continuous data, for example, in our case, then you can use a mean difference or standardized mean difference. For example, every sexual function questionnaire use asking question about the number of satisfying sexual activity. Then you can see every question asking same question. So that means the tool used is same. In that case, you can use mean difference. But sometimes when people are asking about desire and sexual desire or sexual satisfaction, then there are different validated questionnaire out there. Even though your outcome is same, but the questionnaire used is different. In that case, you cannot use mean difference. So because different questionnaire actually use different scaling. So in that case, you use standardized mean difference. So this is a big problem. You need to use standardized mean difference, otherwise your result will be faulty. And if your data is categorical or yes, no, dead or alive or something like that, then you are using Mantel-Hansel risk ratio analysis. Usually, even the continuous data, when you are trying to look at the adverse events, how many people got this particular problem and how many people didn't get that problem, then you can calculate the risk ratio. So as I said, then the question is that what kind of model we are going to use? We already talked about that. I'm not going to talk about anymore about this fixed effect model or random effects model. And using with 95% confidence interval. And heterogeneity, I discussed a little bit. As I said, heterogeneity measures the proportion of variability in the treatment effect between studies, which is assessed using I-square. And as I said, if there is a moderate high heterogeneity, that is more than 50%, then along with 95% confidence interval, it is advised that you should report 95% prediction interval as well. And prediction interval indicates outcome for future studies. So this is the output that published in my paper, that heterogeneity and 95% confidence interval. Sorry. Can you see this graph now?
Yeah, we can.
it's not full screen, but I think it's better. Otherwise, it's not showing somehow maybe animation on transition. So you can see this graph is about satisfying sexual events. So if you look at this left-hand side, overall I squared is 58%, and our overall effect is statistically significant. You can see mean difference is 0.85, which does not include 0. So this is really treatment actually increase your satisfying sexual events. And this is the subgroup. This is surgical menopause women. This is statistically significant. And if we look at natural menopausal women, this is again the second blue diamond, again statistically significant. And then if we combine, they are significant. And the heterogeneity is 58%. The question is that even though we are looking, this is statistically significant, we would like to see whether if we do future studies, then what will happen. So this is because your heterogeneity is more than 50%. If it's less than 50%, then you are not required to do that. So I will go now next slide. Yeah, so you can see the same graph. Now I have added prediction interval. So you can see prediction interval now, the same effect, but 95% confidence interval is different. You can see previously it was 0.52 to 1.18. So it was statistically significant, but now it's really touching your null line, that is 0. So you can see the lower boundary is minus 0.10. So even this is statistically significant effect, positive effect, your sexual satisfied events. But if you do another randomized control trial, it might not have positive impact. It might be, or it might not be. So for other outcomes of sexual function domain, I square are low or pretty much 0. So 95% PI are not required in the paper. So what we did, as I said, the subgroup analysis that we discussed. So this is the overall effect that satisfying sexual events are really positive. That means that treatment has positive impact on sexual functioning. So we want to see whether there is any variation by menopausal status. Another thing we want to see whether mode of testosterone administration. So oral versus non-oral. We have seen that, and we have found that if you are really having your testosterone therapy orally, then this is really impacting your lipid profile. That is really dangerous, and you are going to have your cardiovascular disease later life. So that's why based on that, we have clinical guideline later. I will discuss a little bit about that. And publication status, we also looked at subgroup analysis by published and unpublished RCTs, because we had opportunity to include 2 or 3 very big trials which never published because of null findings. So however, when we did that subgroup analysis, actually it does not impact our estimate. So publication bias, as I said, could be, it is a kind of reporting bias, like a lot of other different biases. So I'm not going to focus more about publication bias, but this is very important. And just note that publication bias could be only, especially the funnel plot would be only reported when you have 10 or more than 10 studies included in your review. If there is a less studies, like 3, 4, 5 studies, then you are not advised to do funnel plot. And you can do also Eager test and Beck test along with funnel plot, because funnel plot has some limitation. I'm not going to talk about that. This is two examples of funnel plots. So you can see the vertical horizontal line is risk ratio, and the sample size vertical line is sample size. So you can see that each dot is study. So this is a kind of asymmetric funnel plots. That means you can see all studies like with small sample size and negative results in the left side, and small studies with positive result in right side. Bottom is a small sample size, top is large sample size. So you can see studies are all over the world. So that means in your systematic review and meta-analysis, your publication bias is really, really very less. That means the evidence you are generating from this review is more robust. But if you look at the right graph, you can see most of the studies are positive studies. That means if your studies are positive, this is more likely to be published, and that has been included in your review. However, you can see the left-hand side bottom with small studies, negative results. These kind of papers have not been published, and you are not including those papers in your review. That means the evidence you are generating is really biased towards positive studies. So what's happened with the, again, going back to the previous things, that how a systematic review actually impact whole clinical practice. So you can see it's so organized way that has been designed that the protocol has been published in a good journal. And you can see Sally Green is here, but Matthew Page is not there at this stage. In the final publication that has been published, #1 endocrinology and diabetes paper, which is Lancet Diabetes Endocrinology. This is the key publication. The thing is that as I said, this is the treatment for up-level treatment, and there is no drug for men. So this evidence has been used based on the systematic reviews and meta-analysis. The first international guideline has been published or developed. And Lancet was very keen to publish the position guideline, but we are not agreed to publish with the Lancet because there is a what is called this embargo kind of what is called what is called, I forgot the name, is rights or property rights.
Copyright thing?
Copyright things and property rights. So our intention, I mean, the group intention was to disseminate that position guideline across the world, and so that all doctors doing their clinical practice can use that evidence for their clinical practice. So you can see that based on our systematic review and meta-analysis, that global position statement has been published in 4 leading journals in the world in women's health. And I'm also co-author of this position statement, which is really extraordinary work. And these are the 2 journals, and this is another 2, and that has been published on the same day concurrently from 4 leading journals. And the good thing is that after doing this position statement, then application has been submitted in Australia, UK, and US for approving this drug for women, which is not approved by the FDA before, but now in Australia it has been approved, and testosterone therapy is really developing by the drug companies here in Australia, and also the working people are working for UK and some other countries. So you can see huge contribution. And when our main paper published, the key publication in the Lancet, it has been disseminated about 1,000 medias in the world. So it's a highly highly disseminated across the world and high interest on that. So this is the reason actually people do systematic reviews and meta-analysis. And our position guidelines said that, look, there are different clinicians in different countries in the world using testosterone therapy for depression and anxiety, which is seriously problematic. And we said that, look, there are different type of, route of administration of therapy, testosterone therapy. We seriously advise not to provide any, oral testosterone therapy, because if you take it orally, then it could be impacting, it will impact your lipid profile, your cholesterol level will be very high. So we are only advising this drug does really effective your improving your sexual function, but that should be transdermal, so not oral. So these are the very important findings, I think, for systematic reviews and meta-analysis, and that could be done for any policy kind of evidence or anything, and not necessarily it should be always clinical practice. So now I think this is all about the process that has been done in a good systematic review and meta-analysis, but I will very briefly show that same results that I did in my paper, but not all outcome. But here, if you have any question, I'm really happy to answer before going to practical analysis.
Yeah, I think you can go ahead, and people, if they have any question, they can put on the chat and we can answer those. And we really need to wrap up because the auditorium we are using, so there is another meeting. So,
when is that?
Actually, it was 30 minutes ago, but
oh my goodness. No, I'm going to finish, but it's really hard.
Yeah, no problem. Yeah, and for all of you, for meta-analysis, the data set, the paper we have shared, and similar data set is going to be used, and the code, you will get everything to practice also. So no worries. And by this time, when the Rakib is getting ready, I'll announce something that you will get all recording and everything for practice. And if you have any question, you can ask to us.
Is
Yeah,
that
please.
okay to start?
Yeah.
I think you guys already have your formal data extraction form, but this is really very specific data that has been used as Stata format. So you can see the study authors and author's name and publication year, and this is T mean. That means our sexual events is continuous data. So we are looking at mean difference. So T means treatment mean, and TSD means the standard what is called standard deviation for treatment, and then T sample mean number of people or number of women in that particular study for treatment group. And P is the placebo group. So placebo, mean placebo standard deviation, placebo sample, and this is the another variable that I call menopausal status. Is short form NS. So you can see some studies are surgical menopausal women, and some studies actually use natural menopausal women. So this is the satisfying sexual events. If you look at the bottom of the east sheet, you can see desire, you can see arousal, you can see orgasm, pleasure, concern, responsiveness, self-image, and also you can see distress, and this is about total cholesterol, there are a lot of data here, but it has been analyzed. As I said to Joel or Razia probably in the yesterday or today, that there are only few graphs in the paper, but there are 47 other graphs as supplementary in the paper. If you really want to look at, you can have a look. But here I'm going to show you this data. Okay, so I'm going to use this data in the Stata very quickly, and you can have the same graphs. So what's happened? Can you see my Stata screen?
Yes, yes.
Okay, so just keep in mind that we are not showing you how to operate Stata. We assume, I know a lot of people are not using Stata, but we don't have scope to teach Stata here. I assume that you know it. So there are different options to import your data, but what I did, I just copy data from Excel sheet, and then this is the data editor. I will open the data editor. Can you see the data editor?
Yes, yes.
And then I am pasting. You can see there is a pop-up window. It says variables name. I will click yes, variable names. And you can see the data I have shown in my, in my Excel sheet is appeared exactly the same way, right? Is that okay?
Yes.
Okay. Now I will now see that you can variable list. You can see study and treatment mean, treatment standard deviation, something like that. And then I will go for can you see my do file syntax as well?
Yes, we can see that.
Okay, so you can see lot of codes because there are many, many graphs have been produced. So what I'm going to do, because once you know the process, I mean the whole process, that is most important. Using that code is not a big thing. You can find, in Google or anywhere, any books. So what I'm going to do is that just copying this one and pasting in command box so that you can see that. So you can see the main command is metan, and then this is exactly that has been reported as variable here, the t sample, t main, tsd. So if you really change your variable name, you just change your name here. You understand what I mean? So what you are writing in your data set exactly should be here. But the thing is that there are some component like sample, mean, and standard deviation for treatment, and sample standard deviation and mean for placebo. That's all. Then you can, how do you want to show that graph? By menopausal status. And then you can remember there are two types of measure modeling. One is random effects, another is fixed effect. You can see the random effects has been written here, and then you can see text size and some kind of texting. How do you interpret your graph? So this is pretty simple thing. But okay, let's see what's happened if we command that one. Can you see the graph? Hello?
Yes,
Yes, we can see.
Yeah, the problem
Yes.
is that you can see the graph is really overlapping some numbers, right? So this is really not readable. And you cannot publish like that. So what you can do, this is the simple thing. I will just, what I'll do, if I go there, you can see probably the text is too big. So what I can do, I can reduce that text size was 175. What I can do, 120 maybe, and then let's see what's happened. This looks better now, right? So you can see exactly what has been shown in the paper. If you match with the published paper, you will see exactly that has been done like that. And if this is the effect size for surgical menopause, the first blue diamond, and the second one is natural menopause, and the last one is the combined effect of testosterone on sexual satisfying function. So you can see that effect size is 0.85 and the confidence interval is 0.5 to 1.80. So please remember this effect size for me, because I'm going to do something now with the fixed effect model. So, right? So I will, and you can see that results window, you can see the numbers that has been shown in the graph that also presented here as a table format. So exactly the same thing. Okay. So what I will do now, I have seen random effects model. Now I will be going to use fixed effect model, and we'll see what's happened with that. So what I'm going to do, I will just delete that random and I will tell Stata, please do it for me using fixed effect. Okay. One problem with the, I should change that 125 maybe this time. Can you see that same figure has been produced, but you can see that effect size is now different. Can you see that compared to the random effects model? And you can see both are significant, but the problem from a methodological point of view or a statistical point of view, and the I-square is exactly same, but methodological point of view, this is completely wrong. We cannot use fixed effect model when you are using studies from different countries and different time frames. Is that clear? And then, oh, sorry. Okay. Then the next thing that I'm going to do is, as I said, that random effects model is really statistically significant, but the heterogeneity is more than 50%. Then what I can do, I want to see when I'm using prediction interval, what will happen. That I shown in the paper. So you can see exactly the graphs I have shown before, as well as published in the paper. You can see that this is actually fixed effect. That's why it's but anyway, I'm not going to change. But you can see when using prediction interval, you can see the lower boundary of the prediction interval actually crosses your null line or zero line. So that means your overall effect is fine, statistically significant, but when you are using prediction interval, that means your future study might not be effective. So this is all about. There are a lot of other things to do, but I think also I'm not able to show you observational study. But I think observational studies doing meta-analysis is really very slim chance to do meta-analysis. If you want to do meta-analysis, then you need to be very careful that you are considering the huge heterogeneity in terms of study design, especially the non-random sampling variation should be considered before going for meta-analysis. I think that's all. I can stop here. Really no time to go further. And Joel, if you want to go further. Thank you. And any question I'm happy to answer. Joel, are you there? Hello, Joel. Or guys, you have question? Can you hear me, guys? I'm audible or?
Yes, we can hear you. I think Joel has gone somewhere. I'm just messaging him to join.
Oh, sorry. Yeah, Rakib, can you hear me?
Yeah, I can hear you. I mean, I'm pretty much done because we can't afford for observational studies right now. And
right.
As I said, that it's really, I think that's a good suggestion by Razia yesterday that clinical trials should be the first priority because this is the key for meta-analysis. But people doing meta-analysis for observational studies, which is really mostly false. So we're not encouraging to do that right now. So it's fine. And we're happy to.
Yeah, I think, are you done? Are you done?
Right, I'm done. And I'm not going to talk about that critical appraisal tools. Once you finish your writing of systematic reviews and meta-analysis, you just go one by one of the many points. It's not Prisma. It's just after writing your review, you just critically appraise your own review. So you can read and you understand. I think it's fine. No need to explain. Yeah. I'm done.
Okay.
Thank you.
Okay. Thank you so much, Dr. Rakib Islam. So guys, you will get this code and Excel data set in Excel, and as well as you already received the risk of bias or quality assessment tool, which I have shared. So later on, we'll share the recording of the session and data set and code also. And the thing is, like, the organization we are organizing this training session, maybe you already hear, it's called SAIST, South Asian Institute for Social Transformation. Today we are starting our 13 years of journey, so 30th anniversary today. And that's why, like, on this day we have organized this one, and the money or a small amount you have provided, we are donating this money to the flood affected people in Bangladesh. So thank you so much for your great contribution also to the humanity. And as a part of the course or whatever, you have lots of opportunities with SAIST. We offer research fellowship and also other opportunities. You have mentorship opportunities also with us. So regarding these courses or systematic review, meta-analysis, or related to research, anything you can write in our page or in our group, and you can ask question. And if you are interested to have any mentorship, then we have those opportunities also. So you are most welcome for that. And one more announcement, I can tell you that, okay, so on 13 August, we are going to organize our second international conference. So you have opportunity to submit your abstract to our conference. So please also, like, I'll request, please submit your abstract and you will have great opportunity. The conference will be held on 13 August in the University of Dhaka. So we are almost ready about everything. So it's going to be one day international conference. So keep your eyes on our page. And Jakera, can you share the page link here? Jakera, can you hear me?
Hi, sir, I can hear you, and Ami, I will provide it as soon as possible.
Okay, yeah, that's all. And if you don't have, if you have any question, please ask, or otherwise we can take a picture, right, Razia? So please
I
turn
think
on your video and
I would like to thank participants. It's not for their own interest. They got really kind heart that we are organizing this workshop for flood affected people. So I really appreciate your participation for this particular workshop, and I look forward your good journey in evidence-based medicine. Thank you.
yeah, thank you so much. And I'll request all of you, please turn on your video, and we're gonna have a virtual picture, and we'd love to share our memories. So please turn on your video, and we are gonna wrap up within 1 or 2 minutes. And thank you so much for tolerating us and being with us, and learn systematic review and meta-analysis. And we wish that you will contribute to produce some good evidence in the knowledge field also through your rigorous systematic review and meta-analysis. So I'll request everybody, please turn on your video. Okay, me too, right? Razia, did you turn on your video?
Yeah, you don't see me?
No. Rakib Bhai?
Yes,
I don't
it's
see
done
it.
on.
Okay, it's done on. I don't know why I don't see. So, okay, we have maybe lots of people, that's why. So in this page, so everyone is, Jazia, you can say cheese or something. What do you want to say?
What everyone prefers.
Okay. See?
Okay, cheese.
Yeah, with cheese or really. Okay.
I'm
I
sure
don't
we are
see any
tired, but
expression.
you can just act.
Yeah, I need more expression. All are tired, you know, so there's no expression. Okay. Okay, thank you so much for joining us. Thank you so much for being with SAGE. Stay connected with us, and we have lots of opportunities also ahead. And please join our conference on 30th August. Have a nice evening. Thank you so much. And thank you all for joining from different countries, different continents.
You should actually tell that from where people joined and how many total people joined. I think that would be a good information to have.
Okay, like for this session, you mean?
Yeah.
Okay, for this session, we got like 55 people registered, and we found like 50 people join. So it's I'll say like really good participation, and we are really happy that you guys are interested in systematic review and meta-analysis. Hail systematic review and meta-analysis.
It was a very engaging session. Thanks a lot, everyone, for your participation. And the questions were great. And we also learned from questions. So I learned from Rakib and Joel as well. So we always learn. This is a learning journey.
Yeah, I didn't learn anything. Thank you. Yeah, so I learned systematic review from these guys. You know, they are expert. Okay, thank you so much. Have a nice evening. Thanks for joining us. Okay, you will also receive certificate in your like email. So don't worry. So you'll get a certificate for this training also.
Okay, any final questions or comments, guys?
Yeah, anything anyone want to share? And
yeah,
anyone
any
can
feedback
if you are
that we
interested.
can any feedback that we can incorporate in maybe later session.
Feedback is really important. Yeah. I think we, and I'm sorry to say that I was really very sick last 10 days, and just come off yesterday a little bit better, and it was really tough. So it's not. I think from our side, it could be more organized. but still, what can we do? We
You have a well-wisher, see? You have a well-wisher, Shimlin Jahan. So
yeah, I just asked her to involve in a systematic review and meta-analysis, but then it kind of postponed now. I'm not sure that I'm going to do that, but I didn't share that with her. Yeah, because it's really, as I said, it's really not easy to lead a systematic reviews and meta-analysis. It's huge work, and I really get very much upset when people are not honest with their work. If you do not understand, I don't mind at all, because I know almost nothing. When working like Julian Elliott or Sally Green, you will feel that you are stupid. But this is fine. This is what we are human being. We can't, in your one life, you can't achieve everything. So this is fine. But your honesty and your integrity is very important in your career and your research, especially. But that's very frustrating for people from low and middle income countries, because including myself, I'm not saying that I'm good, but this is really kind of our culture, that we try to do something very quick, very dishonest, and try to explain things with different different reasons, but we are not saying the truth. Saying the truth is very important. So anyway, I don't want to talk anymore. I'm talking too much, I think. Yeah.
no, it's excellent. Thank you so much, and you'll produce good systematic review and meta-analysis. That's our hope, and contribute like the true evidence we want to see, really. Okay, so we love science.
And
science is
I think this is says to one of the motto is that to upskill and transform these things in young people, that at least what has been happened last, but we want to get few people, maybe not 100%, but if you get at least 20%, this kind of research integrity or academic integrity, that will be huge for future generation.
That's our motto, to transform our society based on like scientific evidence, and that's should be like open science, and also like real science, really. Okay, thank you all. Any comments, anything else you want to add? So please provide us feedback, then we'll try to improve. And we know that with time we mismatch, and also with IT thing we didn't do good. Said Muhammad Sadat, yeah, please go ahead.
Thank you for the whole session. It was nice and amazing for me, actually. I want to know, will you share the slides also, or only recordings?
We didn't talk about slide yet, because in recording everything is there. So we'll talk each other if they think that copyright or other things they feel free okay with that, then we'll share. But in recording everything is there, no worries.
Yeah.
Okay.
And for data, I think there is huge data and code, and that should be misguiding for many people, because those are not using data and things. So I would recommend Joel to use only example that we have shown, because every review is different. So and if you really want to do something, you can get code from online. If you have basic understanding, then it's really easy to rewrite the code, or you can ask us, we can help with that. But analysis code is not an important issue. I think this is not the important thing. Thing is that processes and integrity.
Yes, and yeah, of course, all topics are different, but what's really important is that you know the methodology, so that you can apply to all kind of questions. No one is an expert. I come across so many reviews which I do not know anything about. So I started this review. Thank God I have Joel, who has done a similar research on that. So I asked him for so many things. So it's really good to have some subject expert, but most of the time you don't have one. So you need to read a lot, but if you know the methodology, then only you can apply. So yeah, this is always important. Discipline is very important when you're conducting a systematic review.
Yeah, and yes, Hira, we do organize several courses, workshop and session on research, software application. Currently, we also have one course on Stata, like basic statistics in Stata. So it's going on. Yeah, it's ongoing. It's the 3rd week. So soon maybe we have like academic writing courses, and also we are starting R, programming, and maybe machine learning also soon. So yeah, thanks. So just stay connected with our page, you will get all updated. And okay, one more thing, those people who are going to join our conference, they have like opportunity to join a day workshop, like pre-conference workshop, and it's free. And we are going to teach you like generalized linear modeling technique in R and Stata.
Do share the link with everyone.
Yeah. Facebook page we already shared here, so you can collect, and I can also paste it again.
Ali Hassan, you got some experience. Is that workshop is useful for you? Dr. Ali Hassan?
Yes, sir. It was really thought-provoking, and I have so many new ideas, definitely. And thank you indeed for this great session.
Okay, great.
Well, I think like if no one has anything, and then we can end up, right? Agree, everyone? We can say bye-bye.
Shimlin, I will talk to you later. Some point I will call you.
Okay then.
I will share a feedback link, so please fill that one.
Yeah, we need feedback. We need to improve ourselves.
Thank you so much.
Thank you. Okay, have a nice evening.
Thank you. Goodbye.
Bye.
Goodbye. Thank you. Well, I have a participant here. I need to talk to them. So I think should we talk later? Should we done here?
Okay,
yeah.
Okay, that's fine. I thought that maybe you are waiting to speak with us.
Yeah.
Okay, all the best, Razia.
Razia, she left.
Okay,
she
bye.
left. Yeah. Okay. Bye.